10:30 से 1 बजे के सेशन का रहेगा जो आपने वीडियो को डाउनलोड करवाया
वही है, 10:30 बजे से शुरू होगा, 10 घंटे रहेगा और उसमें भी बहुत जरूरी है ये सब लोग प्रेजेंट कर चुके हैं, सब लोग कह रहे हैं
नहीं मतलब ये 2 से 4 वाले की बात कर रहे हो
नहीं है, वो 10:30 बजे से
ये पूरा।
हाँ 10:30 बजे से स्टार्ट होंगे, फिर वो कंटिन्यू चलते रहेंगे जब तक 4 बजे कराते हैं, जब तक खत्म नहीं होगा।
तो ये मैं एक में कर दूं इनको फिर
मेरे घर में तेरे वो जब तक और पेन ये वो है वैसे ही पड़ा पेन
फिर सीवी तो फिर भी कराओ सबसे पहले आप 9 बजे शुरू होने वाला है। डॉक्टर पीएफ कटोर प्रदीप भाटिया और जे आदि इनके सीवी बहुत जल्दी से पेन देखो पेन इन दोनों को प्रिंट निकालिए। हेलो
Good morning.
Good morning, Apex.
Morning.
गुड मॉर्निंग सर।
सर इसको आप वो कर दीजिए, लीव कर दीजिए मीटिंग।
पंकज गुप्ता सर, गुड मॉर्निंग।
अतुल गांधी, गुड मॉर्निंग एवरीबॉडी।
Good morning, Atul. मंगल छे?
मंगल
हाँ,
के
सर।
साथ है। हाँ।
अरविंद साहब, जय श्री कृष्ण, गुड मॉर्निंग।
जय श्री कृष्ण भाई, गुड मॉर्निंग।
अरविंद भाई मजा में फिजिकल आया तो मजा आवत साहेब।
હા પણ હવે અપેક્ષને ખબર છે હજુ પ્રોબ્લેમ વાળું તો છે જ મારા માટે.
પણ સર સારું રે એકંદરે ઓલમોસ્ટ કોન્ફરન્સ આપણી પતવાઈ છે.
રાઈટ.
વી એન્જોયિંગ ટુ મચ।
યા આઈ મિસ ઇટ.
तो उधर जाते हैं हम लोग।
सर आप वहीं चले जाइए, वहाँ लॉगिन हो रखा है।
ठीक है,
लॉगिन
नो प्रॉब्लम सर। ए साहब, हमें एक जगह शिफ्ट करिए છીએ।
थोड़ी चेंज છે टेक्निकल।
ક્યાંથી લॉगिन કરશું?
यहाँ सर ई जे और
सॉरी અમે ત્યાં चेंज કરીએ, ત્યાં જગ્યા જોઈએ છે।
वहाँ सर 4 हॉल, वहाँ हमने अलग अलग शिफ्ट किया है। सर ए हॉल के जस्ट सामने ही।
આ છે।
कोई बात।
सॉरी वी आर विद इन 5 मिनट्स।
यहाँ सर हेल्प डेस्क लगा है ना, जस्ट वहीं के। वो सर कभी कहाँ है बता दो, उन सर से भी पूछो।
Hello. Hello. Am I audible? Ashok sir.
અરવિંદ,
Arvind sir.
ગુડ મોર્નિંગ.
Good morning sir. कैसे हो?
फाइन.
Okay. I'm audible ना? मुझे लगा था हेडफोन्स चल नहीं रहे मेरे, ऐसा वैसा डाउट आया मुझे।
हाँ हाँ.
यार, how's it going in Gujarat?
या
Ahmedabad doing great?
नहीं, मैं अहमदाबाद नहीं, बड़ौदा है ना मेरा तो।
हाँ नहीं, आप कॉन्फ्रेंस में नहीं हो?
नहीं, वर्चुअल में हूँ मैं।
ओ, मुझे लगा था लोकल लोग रहेंगे। Okay, okay. Good, good. Actually, it's sharp 9 ना?
Yeah. Because of some health reason, I am not been there.
Oh, क्या हो गया सर?
No, because I don't have the immunity, immunosuppressant की वजह से
Oh, okay, okay.
I am not having effect of this vaccine.
Oh, okay. I feel it's sharp 9. We should start. Organizers किधर है? अपेक्ष लाइन पर है क्या? हाँ?
हाँ, मैं लाइन पे हूँ। कैसे हैं आप?
क्या?
गुड टू सी यू, at least virtually.
Good to see you, sir. How nice. हाँ, hello sir. Good morning. क्या चल रहा है? How is everything? अभी अहमदाबाद में हो कि नहीं हो?
हैं?
अभी अहमदाबाद में हो कि नहीं हो?
मैं अहमदाबाद आज घर पे हूँ। एक दिन जाके आया मैं।
अच्छा, okay, that way.
અરવિંદ ભાઈ,
બોલ અપેક્ષ.
તમે તમારું આઈડી ચેન્જ કરી લેશો? અશોક લખેલું છે ને,
હા.
નેમ આવે છે નેમ ચેન્જ કરતા?
ના, I don't know how to do it. અહીંયા છે કશું?
તો હોસ્ટ ને કેવું પડશે.
આ
I think technical team can do it.
આ છે ને મારું લેપટોપ નો है.
હા, તો પણ તમે કરી શકશો.
ડોક્ટર અશોક નું છે.
હા, તો પણ કરી શકશો. Anybody is there from the tech team?
આ રીનેમ છે ને આ રહ્યું. લે કર દો.
Anybody is there from tech team?
Yes, sir.
Is possible to change the name from Ashok to Dr. Arvind?
કરું છું અપેક્ષ.
Okay, fine. Thank you, Amanshi.
Okay, sir. So we are going to start our session.
Yeah, please do.
Pops Award Practitioner Forum. I would like to invite judges Dr. Virendra Sharma, Dr. Pankaj Gupta, and Dr. Arvind Patel.
Sir, can I play the video? Hello, sir.
Yeah.
Sir, can I play the video?
Yeah, I feel if Virendra is not there, so Apeksha is taking care of him, right? Apeksha, bhai? Hello? Hello?
I am here only. Is this session for innovation?
No, this is private practitioners, this one, COPS.
So
COPS
someone has linked, posted same link for an innovation session judging. So I have to leave. And I have to go to the innovation session.
Sir, you can.
Okay. That's why I thought Virendra is busy or something. Virendra इसलिए Virendra ने आपको बोला होगा.
Okay, see you. Bye.
Sir,
मिलते हैं सर. जल्दी
Sir,
मिलेंगे.
you can join 10:45. Same link.
Okay. So now we have to get Virendra is not online, I feel, na? The third judge is, I feel, Virendra. Organizing team, what should we start?
Sir.
Hello.
Yes, sir.
Yeah, can you confirm that there are only two judges or is Virendra also there?
Sir, wait a second.
Virendra, I can't see him online.
No, sir. Virendra is not there.
क्या करना है अरविंद भाई?
Yeah, I think what organizers say. I think we should go ahead. I think.
Because it's already 9:05.
Yeah.
There are 8 papers, so it will take time also. Question answer में भी time लगेगा.
Right.
Actually, organizing team
he can join after one case or something. Oh, in between.
Yeah. नहीं फिर उसका फिर marking sheet system में जाएगा
If somebody is having his number, he can dial him and ask.
नंबर तो है मेरे पास.
डायल करके पूछ लो ना.
मैं पूछ लेता हूँ. Hello. He's not lifting. I feel the organizing team should take a decision. वीरेंद्र फोन नहीं उठा रहा है.
I think we'll wait for another 5 minutes. What organizers say? Because they require the hall also to be emptied after some time.
Exactly.
So we wait for 2 minutes. After 2 minutes, we'll start.
Yes, sir. Perfect, sir. It's already 9:08. 9:10 we'll start.
Yeah. Meanwhile, the first speaker can keep his presentation ready. So we will start after 2 minutes.
Atul Gandhi is presenting something, I feel. Oh, achha, I was going to ask whether he is from the organizing team.
Can we start now?
Yeah, please. I feel we should start.
Okay, sir.
Not audible. They're not audible. Sir, can you hear her?
The audio is not there. Please switch on the audio.
No, please start again. Now,
Respected judges, the
It's fine. Audio is clear.
no,
Yeah, now you can hear.
Okay, sir. Okay.
title of my study is Perioperative Management of Hip Fracture Patients. Are we following the guidelines? A retrospective observational study. Worldwide, 11.6 million patients sustain hip fractures, and these are frail patients with multiple comorbidities and at high risk of complications. Various guidelines have been published to help guide our clinical practice. The Western nations perform annual audits and have hip fracture databases, but there is paucity of studies done at institutional levels. So we designed the study with the aim of evaluating the adherence to the AGBI guidelines at our tertiary care center. The primary objective was to evaluate the adherence to the recommendations made in the AGBI guidelines on the management of hip fracture patients. And the secondary objectives were to evaluate the areas of deficits and the perioperative outcomes, and also to explore the variations in the anesthetic management. The Institutional Ethical Committee approval was obtained, and the study was registered in CTRI. The hospital information system was used to obtain the patient records. All patients of age more than 65 years who were posted for proximal hip fracture surgery from January 2020 to January 2021 were included, and the records of the included patients were examined to look for the details of in-hospital care pathway using a predefined proforma. 12 key performance indicators were identified from the guidelines, and a score of 1 was assigned for compliance to each indicator, and total score for each patient was calculated. The key performance indicators were that the patient should be admitted to ward within 4 hours of arrival, and a nerve block must be given from ED. They should be assessed by a geriatrician, and they should undergo a cognitive, falls, and nutritional assessment. They should be operated within 48 hours of admission and should be managed by a consultant anesthesiologist. A nerve block must be given for postoperative analgesia. Intraoperative hypotension should be avoided, and they should receive thromboprophylaxis and must be ambulated on the first postoperative day. Details of other details of perioperative care, demographics, postoperative discharge destination, length of hospital and critical care stay, postoperative complications and outcomes were also noted, and the records were followed up till 30 days of admission. The sample size was calculated using the proportion method. A previous audit showed that 71% of the patients were operated in less than 48 hours, and the sample size calculated was 123. Descriptive statistics was done, and continuous data was represented as mean with standard deviation, and categorical data was represented as frequency with percentage. 152 patients were posted for surgery. 2 were excluded because they refused to consent for surgery, and of the 150 patients who underwent surgery, 22 were excluded because of missing data, and 128 patients were included in the first final analysis. This table shows the demographics of the included patients, and from this we can see that up to 40% of the patients belong to ASA class of 3 or 4. This graph shows the adherence to the key performance indicators. Although most of the patients were admitted to ward in less than 4 hours of arrival, only 12% of the patients received a nerve block from ED. None of the patients were evaluated by a geriatrician or received a cognitive assessment. More than 70% of the patients were operated in less than 48 hours of admission and were managed by consultant anesthesiologists. 32% of the patients developed intraoperative hypotension. Less than 40% of the patients received a nerve block for postoperative analgesia, and 64% of the patients were mobilized on the first postoperative day. This graph shows the total key performance indicator scores, and from this we can see that majority of the patients had a score of 6 to 7, and none of the patients had a score of 12. And among the patients who had a delayed surgery, antiplatelets was the most common cause for delay, followed by medical optimization being the second common reason. And it was encouraging to find that only 6.7% of the patients received general anesthesia in compliance with the recommendations that radial anesthesia should be preferred for these patients. And among the patients who received a subarachnoid block, up to 40% of the patients received a dose higher than the recommended dose of 10 mg per bupivacaine, which made them prone to develop intraoperative hypotension. 52 patients required postoperative critical care admission. Mean length of hospital stay was 3.5 plus or minus 0.7 days, whereas mean length of critical care stay was 1.8 plus or minus 0.5 days. 14 patients developed pressure sores, but there were no cases of in-hospital falls, venous thromboembolism, or bone cement implantation syndrome. 16 patients developed postoperative complications, and the most common complication was aspiration pneumonia. 9 patients died in the postoperative period, and the mortality at 30 days was 7.03%. Now, comparing our results with the 2020 report from the National Hip Fracture Database of UK, 68 patients were operated in less than 48 hours versus 71% in our study. 81% were mobilized the day after surgery versus 64% in our study. And 30-day mortality rate was 6.5% versus 7.03% in our study. Moving on to the limitations. All limitations inherent to the retrospective study are applicable to our study also. The data was obtained from medical records, and some aspects of care may not have been documented, which must have led to underestimation of the care received, and the follow-up was limited to 30 days of admission alone. And to conclude with, the perioperative management of hip fracture patients at our hospital is at par with Western nations in several areas, though few areas of severe deficits were identified. High mortality implicates the need to provide optimal care to these hip fracture patients, and the quality of care can be improved only by reviewing our practices, and there is also the need to formulate guidelines tailored to our practices, to our resources. These are my references. Thank you for your patient listening.
Which nerve block you have used?
Sir?
Which nerve block you have used for pain management?
Sir, I regularly give PENG block now. Currently, I am practicing PENG block, pericapsular nerve block, for postoperative analgesia.
You are using only for the postoperative period. You are not using preoperative phases before giving spinal?
Sir, there is a limitation of time. Our surgeons are not willing to wait for it. Because for PENG block to act, we have to wait minimum of 30 minutes. As I discuss with our surgeons, they are not willing to wait for that time. So I give ketamine and then shift the patients onto table without, they are not having pain because of the ketamine. But for the postoperative analgesia, I regularly give blocks. But this my audit shows the practices done by all the practitioners at my hospital. So many of them are not using having the practice of giving nerve blocks for the postoperative analgesia, which is a severe deficit that was noted in our study.
What was the thromboprophylaxis you were using, madam?
Sir, most common thromboprophylaxis is mechanical only. Very few, very low proportion of patients received pharmacological thromboprophylaxis. All patients, most of them, more than 80% of the patients receive mechanical thromboprophylaxis only. And the surgeons are very reluctant to use pharmacological. Mechanical, we are writing in our orders, and that is being followed.
How did you manage the hypertension in those patients that you had?
Sir, we mostly use ephedrine only. Only very few, unless the patient is at high risk of MI and all that, we use phenylephrine.
Okay. One suggestion to you, I mean, it was
Yes,
a good talk. One suggestion will be, you are the boss in the operation theatre.
Yes, sir.
Let that message go very clear to your surgeons.
Sir,
And
yes,
And block definitely makes the patient more comfortable when you are giving the spinal.
Spinal, yes, sir.
So,
Sir,
try to
but
tell,
I've been able to intervene in several other areas, like many of them are now taking up the patients even on antiplatelets at an earlier period. They are willing to take the risk of the minor risk of bleeding, but versus the improved care with early surgical management. I've been able to improve all those aspects.
good, but then,
And also, I have been started doing under patients who are under severe cardiac risk. We are doing now under lumbar and sacral plexus blocks. I have started doing that also. That is also because we are a tertiary care center. We get very high risk cases which are rejected from several other hospitals. So that has also made a big difference.
thank you. That was a good presentation.
Thank you, sir.
Thank you. Good.
Hello, respected judges, seniors, and colleagues. Myself, Dr. Mangal Dave, practicing and consultant anesthesiologist since last 18 years. And since last 12 years, I have been practicing at Gukul Super Speciality Hospital, Rajkot. Today, I am presenting observation and documentation of minimal cervical spine movement during intubation with TASCOPE video laryngoscope. Neck movements and potential risk of damage with neck movement to spinal cord during intubation is area of concern, and it is especially very much of concern when suspected or proven damaged cervical spine and edematous cord are present. Why? Because in order to intubate the patient, we have to align the oral, pharyngeal, and laryngeal axis. And for aligning these axes to visualize the larynx, we have to extend the neck in order to intubate the patient. To overcome this challenge, we use TASCOPE video laryngoscope, which is a lightweight plastic video laryngoscope with 5.5 millimeter endoscope camera and a special channel to introduce bougie. TASCOPE is a hyper-angulated blade, and it has it can enter minimal mouth opening of 1.5 centimeter. Practically, with TASCOPE, we bring our vision inside the oral cavity, and that is why we don't have to extend the neck much. These are the videos showing intubation with TASCOPE. A hefty male patient after induction with conventional agents and relaxant being intubated with TASCOPE. First, the scope is entered, the larynx is visualized, and then from the channel of the bougie is introduced, and then once the bougie is inside the larynx, over the bougie, the endotracheal tube is threaded. Another video is of a lady, old age lady with no neck being intubated with TASCOPE. The lady is conventionally induced and relaxed, and TASCOPE is introduced. The epiglottis and vocal cords are visualized, and the bougie is introduced. Both the videos, you can see there is no undue neck movement or no much neck extension is required while intubating with TASCOPE. Another video showing a patient with Philadelphia collar in situ to restrict the cervical spine movement is being intubated with TASCOPE. On the right hand side of the screen, you see is the actual vision which is shown by TASCOPE. A beautiful vision of larynx and epiglottis is seen. And right now what you can see is the introduction of bougie inside the larynx and threading of tube over the bougie. So even the neck is fixed with Philadelphia collar. We can intubate the patient easily with TASCOPE. So we observed all this, and to document this, we did is fluoroscopy of neck movement. While we were intubating with Tasco, we did documentation, fluoroscopy, and recorded the actual movement what occur with intubation with Tasco. You see the very minimal neck movement. Right now, the bougie introduction, and after the bougie introduction, the threading of endotracheal tube over bougie. Intubation is done, Tasco out, the bougie out. On the right side, what we see is the recording of the fluoroscopy. The introduction of Tasco video laryngoscope. Now you can see the plastic blade coming inside the oral cavity. Bougie is not radio opaque, so it is not seen. But once the intubation is done, as such, there is no neck movement. And once the intubation is done, you can see the scope being taken out. Yes, the scope is out now. So there is very minimal movement at cervical spine and atlantoaxial joint. Thus, to conclude, Tasco video laryngoscope, which is a combination of hyperangulated blade with a channel to introduce bougie, is a very helpful tool for minimizing neck movements during intubation. Thank you.
Hello.
Yes, sir.
Yes, Naval sir, how are you? It was a nice presentation as always. Always
Thank you very much.
Good to see you active always on all forums. Why did you name this as Tasco?
Sir, the Anesthetic Society, basically we will making this scope from the video in task group. So from that we have derived the term task scope.
So you thought it was the right thing, or it was a justifiable move, or what was it?
I'm sorry?
Was it a justified move, or you should have named it something else? Hello, can you hear me?
I'm not getting your question, sir.
Okay. Do you use this scope for intubating normal patients also?
Yes, sir. All normal patients we use, and to practice, basically to get acquainted with the scope, practice on normal patients is very much required, sir.
Okay, so you will recommend it to be used for every patient or only for anterior larynx?
No, sir, for all the patients.
Okay, the ease is
if we introduce it full, it is hyperangulated. If we don't introduce the full scope, sir, it will act as a normal scope, sir.
Okay, but the hyperangulation might create some problems also, I feel.
Yes, sir. Normal also we can do. We don't have to extend the neck of the patient, and even don't have to put in the pillow. In the neutral neck position in normal patient, we do with task scope, sir.
Even the sniffing position is not required.
Not required, sir. Not required.
Okay. Thank you. Thank you.
Thank you, sir.
Arvind, sir.
No, it's okay.
Thank you, sir.
Thank you.
Sir, can I play next video?
Yeah, please.
Hi, I am presenting anesthesia management of high-risk cardiac patient for lower limb vascular surgeries. CLI is defined as chronic ischemic chest pain due to the arterial occlusive disease. PVD is marker of multisystemic atherosclerosis. Challenging during anesthesia due to the comorbidities like elderly, hypertensive, diabetic, cardiac, renal, and respiratory disease. 60% patient has severe coronary artery disease and symptom masked due to the limitation of exercise. Perioperative cardiac complications combined lead to the incidence of the cardiac death in AMI more than 5%, 30 days mortality 5 to 8%. Thus, we study 25 high-risk cardiac patients presented for infrainguinal lower limb vascular surgeries under peripheral nerve block with aim to provide adequate anesthesia, stable hemodynamic, good post-operative analgesia, and to avoid JA as well as central ventricular block. Written informed consent was taken. 25 patients of ASA grade 3-4 age more than 18 years posted for unilateral lower limb intra-inguinal vascular surgery selected with exclusion criteria shown in slide. All patient was examined, investigated, was scored for post-operative analgesia and alternative plan of anesthesia explained. 6-hour MPO kept. All cardiac medication, including antiplatelet, continues. After taking patient to the OR, baseline vitals were noted, IV line secure, and fluid started. Injection midazolam was given for sedation, oxygen was started. Patient was positioned for the block in lateral decubate position with operative limb in non-dependent position. As shown in the slide, after proper aseptic and antiseptic precaution, landmark for lumbar sacral plexus block was marked with help of stimulating needle and peripheral nerve stimulator. Lumbosacral block was given. Bupivacaine 0.5% 12.5 ml plus lignocaine 2% 12.5 ml was given after negative aspiration at both sides. Onset of sensory blockage defined as the time from injection of the drug to the loss of pubic sensation over the site of incision. Onset of motor blockage was defined as the time
अरे आप
from
जज हो एक वो सेशन में आप तो
injection
आए
of
नहीं हो,
the drug to
तीसरा
the
प्रेजेंटेशन
for
चल
the
रहा है.
lumbar block inability of the patient to extend knee
आप
joint,
जज
for
हो
sacral block
जज.
inability to extend dorsally plantar flexor ankle joint. Intraoperative vital monitor till the end of surgeries. Onset of sensory motor block was noted. Fentanyl given for sedation and use of GA in any patient was noted. Post-operative vitals was monitored for 24 hours. Perioperative pain was assessed by the VAS when it was more than 4 injection nalbuphine 10 mg given. Duration of post-operative analgesia was noted, and if any complication was there, it was noted. Demographic data table and duration of surgeries as shown in the slide. Slide 2 shows perioperative heart rate and mean arterial pressure increase in 2 patients by more than 10 to 20% from the baseline in only 2 patients. Sensory onset and motor onset for lumbar block was 16 and 19 minutes, while sacral block 14 and 17 minutes. Duration of postoperative analgesia was 6 hours. 2 patients required GA and 1 mortality was there due to malignant VT. Managing cardiac patient for non-cardiac surgery is daunting task. With era of minimal invasive surgery, erase protocol, newer technique, and more use of anticoagulant reduce the use of epidural and favor regional block nowadays. Urexal block easy to administer, high success rate, but in cardiac patient more hemodynamic instabilities and cardiac patients are on antiplatelet. General anesthesia commonly used and preferred in cardiac patients. Induction and emergence from CA should be smooth to avoid cardiovascular instabilities. Peripheral nerve blocks were very popular for upper limb surgeries and safe in cardiac patients. But for lower limb surgeries, 2 separate plexus need to block which are deep seated, so high volume required. But with use of the newer technique like USG and peripheral nerve block, we are gaining popularities. As shown in the slide, the combined lumbosacral plexus block provide complete anesthesia of ipsilateral lower limb with good postoperative analgesia. So we study this method as a anesthesia for the high-risk cardiac patient for the lower limb vascular surgeries. Padali et al. Conclude combined lumbar sciatic nerve block is a safe and effective as compared to the spinal in patient with comorbidity disease for the posted for lower limb orthopedic surgeries. HOAM et al. Has case report for reduction of hip surgeries in patient with severe aortic stenosis, but none of them has studied the block in high-risk cardiac patient posted for lower limb vascular surgeries. As this is a safe and effective method, so we thought to study this. In our study, onset of sensory and motor blockage for lumbar and sacral plexus was 16 and 14 minutes and 19 and 17 minutes respectively. This is comparable with Rupalsa et al. Rupalsa et al. Studies combined lumbar and sacral plexus did not affect the hemodynamic. Adali et al. Studied the same. Michael et al. Studies the combined source compartment sciatic nerve block did not affect the cardiac index. In our studies, there was no sudden or intense variation in hemodynamic parameters. Embry et al. Suggests 3 key factors to avoid major complications as shown in the slide, which was taken care and there was no complication in our studies. Osnally et al. Suggests an epidural spread is a more common in lumbar block, which was not occur in our studies. 2 patients required GA due to the inadequate effect, and 1 patient with ejection fraction 15% had malignant VT 2 hours after surgery, which could not be revived despite all resuscitation. H.K. Bado et al. Conclude PNBs are the effective technique for anesthesia with good postoperative analgesia. In our studies, postoperative analgesia was remained for 6 hours, which we can increase it by adding the drug like tramadol, and fentanyl, which was studied by Rupal Shah and Bansal et al. Administration of anesthesia for any surgeries need to meet demand of surgeries, patient comfort, and efficiency of anesthetics. Combined lumbar sacral plexus blocks, simple, safe, effective, provide stable hemodynamic in perioperative period, less complications, excellent post-operative analgesia, shorter hospital stay, and lesser the cost. In nutshell, combined lumbar sacral plexus block are better alternative to the neuraxial and general anesthesia in high-risk cardiac patient for unilateral infrainguinal lower limb vascular surgeries. Thank you.
Dr. Hetal, can you tell me infrainguinal surgery can be done with other type of the blocks? Which other types of the block you can use instead of lumbar plexus and sacral plexus block?
Blocks are you taking? Epidural or these?
No, I am asking for the peripheral nerve block only. Because it is an infrainguinal surgery, am I right?
Yeah, sir.
Okay, so plexus block is always having some sympathetic blockade and it can cause hypotension. Many times the drugs will spill over to the epidural and cause hypotension. So in a high risk patient, can you do it under a femoral and sciatic nerve block?
Yes, sir.
So for the hip it is fine, but for the most of the peripheral vascular surgery, if you have chosen the femoral and sciatic nerve block, that would not serve the purpose of a high risk patient to do safely.
But sir, in femoral, the incision site is might be above the inguinal regions sometimes, little bit for vascular access. So during cardiac surgeons they might need some so it may be escape. So we need
no, it will never escape. Even from the femoral root also you can give all the three in one block. If you give just a little pressure below the injection site and inject the solution of around 30 ml, it can give up to the most of the three nerves would be getting blocked.
Okay, sir.
So that would be much safer to do it. That is what I am just trying to tell you. I am not saying that it is absolute contraindication, but in a high risk patient, I would prefer the femoral with sciatic nerve block.
Yes, sir. We can take a note, sir.
Yeah, Dr. Tejas, what was the backup plan if you had total failed block?
Sir, we will do under TIVA with supraglottic airway device.
Why not straight away do under TIVA then? Why have the risk of having hypertension? Straight away give GA to all these high-risk patients.
Patients are very sick patient, 5% EF, 10% EF, that might not tolerate the TIVA also.
Exactly. So that's why the backup plan has to be perfect. You require a perfect backup plan. You require a perfect backup plan. If TIVA is more complicated, you should have a safer backup plan.
GA is always safer, sir. We know.
Exactly. That's what I was trying to get at you. Have you ever tried unilateral spinal for all the high-risk cases?
Sir, pardon? Have you?
Unilateral spinal anesthesia.
Unilateral we have given, but still it more hypotension, chance of hypotension in that very high risk 5%, 10% EF patients are also posted for retina. And that patient we cannot take a chance to give unilateral ejection fraction 10% EF or like that.
Yeah, because lumbar sympathetic sometimes lumbar sympathetic can give you a lot of hypotension. Sometimes. So it can be very dangerous in these patients.
Okay, sir.
Anyway, thank you. Thank you.
All. This is greetings from Dr. Hetal Shah. Today I'm going to discuss about anesthesia management of bilateral bronchopleural fistula for BPF required. This slide changing takes some time. Sorry for that. Tuberculosis was one of the most common infections we faced in India, and now COVID-19. Both of them targets the parenchyma of the lung, and more severe infections can cause pneumothorax, and non-healing of it leads to bronchopleural fistula. It leads to the persistent pneumothorax, collapse of the lung, and mediastinal sepт. BPF is the most dreaded complication, and it adds to the morbidity and mortality, especially if not closes spontaneously with the medical management. The incidence remains only 8 to 12%, but the mortality rate is as high as 30%. From anesthesia perspective, BPF can be classified into three categories. A small BPF where there are no symptoms or very minor symptoms, and it has a very small or no effect, negligible effect on anesthesia. The large BPF patients are symptomatic, oxygen-dependent hypoxic, tachypnic, and they can hardly hold breaths. And IPPV is difficult or even impossible despite the maximum gas flows. The medium category BPF falls into these two, where the IPPV can be still possible with normal flow of gases, which is about 8 liters per minute. We had about 5 cases, and all patients developed BPF post-COVID and came to us in 2 months' time post-COVID with non-healing of BPF. The predominantly were males. They were all tachypnic. Breath holding was average 8 seconds, so PFT was not possible. They needed about 10 liters of mask oxygen to maintain the saturation about 94 to 96%. All needed thoracotomy, and they all had bad lungs because of the recent COVID, so expected high airway pressures and low PO2. We were posted for decortication and biopsy with repair of BPF. And as you can see in one of the patient, on normal talking or normal breathing also, he had a lot of gas which was getting lost in the ICD bag. And these were the X-rays, CT scan showing the bilateral pneumothorax, subcutaneous emphysema, and typical COVID bad lungs parenchymal disease. So since all these cases were fell into the category of large BPF, managing under general anesthesia would have been difficult as there would be the substantial loss of volume which happens with IPPV. So we planned ESP block, but however, one patient crashed in ICU pre-operatively, and hence that was managed with general anesthesia. Rest 4 we gave ESP block. We made a pre-operative visit, and whatever we can improve the lung condition we did. We reassured and discussed about our plan with all the patients. Routine things were done, except arterial line and central line were placed under local anesthesia, and we gave chlorpheniramine injection to the block patient as an antitussive action. Both ICDs were kept functional till the thoracotomy was done in all patients. Erector spinae plane block was given with the standard approach, and drug was deposited below the erector spinae muscle. We gave over 20 ml of 0.5% bupivacaine because we wanted anesthesia effect. Position was kept depending on the surgeon's choice. All routine with invasive pressure monitoring was monitored. Anxiolysis was given with the midazolam, and patient was made comfortable by supplemental oxygen. Only 2 patients needed inotropes in form of noradrenaline. Desaturation was only found in a general anesthesia patient as expected. None of the block patient had a major desaturation. Duration of surgery was around average of 1.5 hours, and no additional analytic requirement was noted. General anesthesia patient had a stromy post-operative course, and we lost him on a day 5. This was the incision which was kept, and this was the necrotic debris material which was removed from patients. Less invasive surgical techniques development, the introduction of ERAS pathway, and the increased use of anticoagulation therapy led to the use of epidural anesthesia in a declining phase. Hence, the interfacial plane block is the current hot topic in regional anesthesia. Erector spinae plane block is a novel interfacial paraspinal plane technique that was initially used by Forero et al. And it is an easy to perform regional anesthesia technique with a wide range of clinical applications. It can be an alternative option to thoracic epidural analgesia and paravertebral blocks, especially when these techniques are contraindicated in patients with anticoagulations. This block has a good safety profile as well. As with all facial plane blocks, the aim of ESP block is a compartmental spread. However, the working theory is that because of the discontinuity of the intercostal muscles, local anesthesia diffuses anteriorly to the ventral and dorsal rami of the spinal nerves and through the intertransverse connective tissue to enter into the thoracic paravertebral space, hence gives anesthesia. Chin, Adhikari, and Schwartzman et al. Have suggested that the ESP block can be an alternative analgesia option to the paravertebral block. If local anesthesia was deposited deep to the erector spinae block, which we did in all 4 patients, apart from the desired analgesic effect, it also provides a cutaneous sensory block, which helps in the surgical incision. Till date, only one randomized study has been published looking at the use of ESP blocks in adults undergoing video-assisted thoracoscopic surgeries, that is called VATS, where they found that there was a statistically lower opioid consumption and pain score in the ESP group. This study suggests that the ESP block is a suitable opioid sparing block for patients undergoing VATS. Hence, I can conclude that ESP block can be considered in patients who can be difficult to manage with general anesthesia for thoracic surgery. Thank you.
Hital, what sort of hospital are you practicing in?
I'm with Narayana Multispeciality at Ahmedabad.
Okay. And how often do you give electrospinal blocks otherwise in other surgeries?
No, we usually don't like this. COVID has actually made, and this kind of cases has made up thinking like, no, what can we do for this kind of patients where no general anesthesia is really a big challenge because of the loss of volume which happens with IPPV. So we started doing in 2 patients with routine posted for like decortication routine patients, and then we got some confidence and we started doing in this kind of patients.
Exclusive.
There is not much literature for using this block for operative procedure.
Yes, as I mentioned, there is only one study which has been published.
How you are sure about the visceral pain?
Usually this parietal pleura has some pain, but visceral pleura and the lung doesn't have much of the pain. So and these patients are really sick, sir. So we
I didn't disagree on the point that you have used a novel method of using this thing, but
yes,
my only worry is that by chance if this patient is having a pain and you start your surgery and visceral pain is there, how you have thought to give a supplement or what to do?
So we thought of giving injection nalbuphine as a rescue analgesia.
But that may would you think that it is sufficient?
So the backup plan was GA always. I mean, if the patient is not comfortable, if the surgery is not comfortable, then we thought of giving general anesthesia to all the patients. That was a backup plan. Okay. But yeah.
Okay.
But I thought injection nalbuphine would give some good analgesia effect in these patients if there is a visceral pain.
No, the reason why I'm asking these questions to you, see, this block is never be remain in the outer plane. There are the drugs will go anterior also, and
yes,
and some cadaveric dissection has found that even giving the erector spinae block, the drugs goes to the foramen too and spreading around the structures. So
it
takes care for even visceral pain.
Yeah,
so
if you
have not used much of a general anesthetic IV agent like a ketamine or something during your surgery, I would not put an LP to reduce the pain or whatever. No narcotics can prevent the surgical pain. So what I personally feel, the drug must have penetrated to take care of all types of the pain. So
if you have looked at my slides, the working theory is saying that because of these intercostal muscles are blocking it, this drug goes to the ventral rami also.
No,
dorsal rami and ventral rami, and that is why probably the A delta.
That is a general belief. That is a general belief that ventral and posterior MI are been affected, but the drugs still spread further. That is what I'm trying to say.
So there is a possibility. Yes, there is a possibility that it can go through the paravertebral foramina into epidural space. There is still a possibility. Yes, there is a possibility.
And why there was a hypotension? Why there was a hypotension? Was it an intraoperative hypotension or after the block hypotension was there?
Yeah, so 2 patients, as I mentioned, 2 patients needed noradrenaline. But whether, because they were such a sick patient, so whether it was a sepsis induced, whether it was like when you have a surge because of the surgery, that would have led, or because of the block, we
At what stage the
don't know.
hypotension was?
That say particularly to the block. I beg your pardon, sir?
At what level the hypotension was there? After giving
Some
block or
internet
during the
issue
surgery? I think the connection is
No,
lost.
we had after opening of the chest during surgery. So there was a multiple possibility.
There may be the vasovagal too.
Am I able to?
Yeah, you are
Multiple
able to.
things, sir. It could be mediastinal compression. It could be surge. It could be these patients were so bad, so they may be having some amount of sepsis. So multiple possibilities were there. So I mean, we cannot pinpoint to one point why the hypotension has happened in this patient.
Why you have not thought of using a high flow machine?
High flow machine.
High flow nasal.
We don't have high flow in OT.
Okay.
Then we have to shift it from ICU. So that was not in a COVID scenarios. We didn't want to expose much of the things, not to patients.
Okay, fine. Thank you.
Thank you, sir.
Can I play next?
Yeah, please, please.
Okay.
Just give me 30 seconds.
Okay.
Yeah, you can go ahead. This is a fifth case. Am I right?
Yes, sir. Yes, sir.
He's going in the line now.
No, sir. Recorded video.
This is ABS 3718.
Yes, sir. Yes, sir.
Please go ahead.
Good morning to respected judges, teachers, my dear friends. Myself, Dr. Dinesh Prajapati from Murjibhai Patel Urological Hospital, Nadia. Today I am going to present our research paper on comparison of ketamine, dexmedetomidine versus ketamine propofol combination for sedation during short duration urological procedure, a prospective randomized study. Nowadays, daycare surgery are becoming popular. Cystoscopy, urethral balloon dilatation and calibration, DJ stenting, cystoscopy, hydrodistension, etc. are the daycare urological procedures. We need short-acting agent which is defined in its work. An ideal short-acting agent should have good sedative, anxiolytic, and strong analgesic property. Ketamine, which is a dissociative anesthetic, is having all the property which we needed. It acts by inhibition of sensory perception, which is mediated by the blockage of N-methyl D-aspartate receptor. Emergent reaction and cardiostimulatory response are the main drawback of ketamine uses. Dexmedetomidine has now become commonly used drug in anesthesia practice because of its property like anxiolytic, sedative, analgesic, anesthetic sparing, neuroprotective effect. It maintains sympathoadrenal and perioperative hemodynamic stability. This property suggested it can be suitable adjunct to ketamine anesthesia. We started our study with primary objective was to compare the safety and efficacy of ketamine dexmedetomidine versus ketamine propofol for sedation during short duration urological procedure. Our secondary objective were to compare the emergent delirium, post-procedure pain score, and recovery time. After obtaining ethical committee approval and written informed consent from the patient, the study was registered under Clinical Trial Registry of India. A prospective randomized study was conducted for 6 months duration in 60 patients. Our inclusion criteria were age between 16 to 65 years, ASA status 1 to 3, short duration endoscopic urological procedure less than 45-minute duration. Our exclusion criteria were patient with upper respiratory tract infection, psychosis, increased intracranial tension, neurological disease, and glaucoma. History of hypersensitivity to study drug and patient refusal for giving consent. Patients were randomized into two groups by using equal number random block technique. Group KD receives dexmedetomidine 1 microgram per kg over 10 minutes intravenous, followed by ketamine 1 milligram per kg initial dose, followed by top-up dose 0.25 milligram per kg in titration. Group KP receives combination of propofol 1 milligram per kg with ketamine 1 milligram per kg initial dose, followed by same combination top-up dose 0.25 milligram per kg in titration. Standard monitor were used. Heart rate, respiratory rate, NIBP, arterial oxygen saturation were recorded every 5 minutes. Glycopyrrolate and metoclopramide were used as a pre-medication. Patient will receive oxygen supplementation via nasal cannula 2 liters per minute only when SpO2 dropped below 95%. Sedation score, delirium scale, post-operative pain score, and recovery time were recorded. Ramsey sedation score was used, range from 1 to 6. Our target was RSS should be more or equal to 5. If target is not achieved, top-up dose were given. Memory delirium assessment scale was used for scoring of delirium after 30 minutes of last ketamine doses. Total score ranged from 0 to 15, which consists of 5 items: reduced level of consciousness, disorientation, short-term memory impairment, impaired digital span, reduced ability to maintain and shift the attention. VAS scale was used after 60 minutes of procedure for post-operative pain. Recovery time, which was calculated from the end of the procedure till achieving post-anesthesia recovery score of 9 to 10. Total dose of ketamine, incidence of nausea and vomiting, apnea or desaturation were recorded. Statistical analysis. Sample size of 30 patients in each group were calculated for 90% power, 95% confidential interval, and 5% alpha error. Independent sample t-test was used to compare the two mean, and chi-square test was used to comparing proportion and frequency between the two mean. If p is less than 0.5 is considered, p is less than 0.05 is considered to be significant. Total 60 patients were recruited into the study. 4 patients were dropped out or excluded due to prolonged procedure time and conversion to GA. Both groups are comparable by age, sex, height, weight, BMI, and ASA status, duration of surgery, and type of the procedures. Mean heart rate was significantly lower in KD group during 5 minute, 10 minute, and 60 minute time point, while rest of the time there is no significant difference were observed. Mean arterial blood pressure remained lower in KD group as compared to KP group, but there is no significant difference noted. Mean respiratory rate remain similar in both groups. Saturation of oxygen is fall at 5 time point in KP group as compared to KD group, while rest of the time there were no significant. Mean sedation score remain comparable in both group all time point. Nausea and vomiting incidents are more in KD group as compared to KP, but not significant, while apnea incidents were more with KP group as compared to KD group, which is highly significant. Total ketamine requirement is more with KD group as compared to KP, but not significant, while time to achieve post-anesthesia recovery score till 9 is more with KD as compared to KP, but not significant. There is no association of both group with delirium scale. So, in summary, in our study, there were no statistical significant difference observed in mean arterial pressure, respiratory rate, sedation scale, delirium scale, post-operative pain scale, recovery time, and nausea vomiting. But there is a significant reduction of heart rate in KD group during initial time period and at the end of the procedure, while apnea episode is more with the KP group as compared to KD group, while ketamine requirement was more with KD group as compared to KP group, but not significant. So the study suggests that ketamine dexmedetomidine combination for short urological procedure has no respiratory depression, better hemodynamic stability. It is an effective, reliable, and safe alternative to ketamine propofol with comparable recovery time. These are my references. Good morning, sir.
Hello, Dr. Dinesh.
Yes, sir.
Yeah, see, I appreciate you trying out this combination. You concluded directly by saying that it is better than ketamine propofol. But is ketamine propofol the gold standard for short urological procedures?
Yes, sir. Ketamine propofol combination, it's commonly used in our practice. And then we have planned for the dextromethorphan and ketamine combination.
Okay. Did you find the relaxation was adequate?
Sir, all are the endoscopic procedures, so there is no need of relaxation.
Okay. And why did you choose only patients about 16 years of age? Why not pediatric age group?
Majority of our patients are adult patients, so I have used that group of patients.
Okay. Next
We
question.
also have a pediatric, but that sample size is also less for that.
Okay.
I have included only adult age group.
Okay. And did you ever think of combining both of them in the same syringe or always separate syringes?
You are
take in the same syringe?
Ketamine propofol in same syringe and dextromid and ketamine in separate syringe.
Why?
Dextromid, sir, in this study we gave over 10 minutes slowly, and after the dextromid is over, then we have supplemented with ketamine for the sedation.
But what if you were combined both in the same syringe? What would be the problem?
Sir, we have in the literature I have not found any literature to support my study for combination of ketamine and dextromid.
Okay, that's the right answer. But I do a lot of pediatric cases using this combination, and of course, when I am looking for some literature, the results are very good, definitely. Thank you.
Okay.
Thank you.
So I will start.
Yeah.
Okay. Thank you, sir.
By your presentation, I cannot find out much difference except for the temporarily apnea with ketamine propofol group.
Yes, sir. Almost, sir. Both are similar, efficacy and safety. This is not a inferiority study. This is just a comparative study to both are equal or not. Our aim. And also, there are only minor differences found in the point of hemodynamic stability for the post-operative period. And second one is no respiratory depression found in KD group. But with KP group, apnea is more. Rather, that is the only significant we note.
Okay. Thank you.
Thank you, sir.
Can I start the video? Sir, can I start the video?
Yeah.
Okay.
Good morning, ladies and gentlemen. At the outset, let me thank the organizers for giving me a platform to share my clinical experience. I get you greetings from Sultan Qaboos Comprehensive Cancer Center at Muscat, Oman. Ultrasound has become an inescapable requirement in the armamentarium of anesthesiologists. Pre-procedural ultrasound to identify the spinal spaces has been proven to be a better alternative in comparison to the traditional landmark conventional approach. And in the past decade or so, the real-time acquisition of images to conduct spinal anesthesia with ultrasound has also gained importance, and multiple studies have evaluated the efficacy of this real-time ultrasound guided spinal anesthesia. However, there has been no study which has compared the real-time ultrasound guided spinal anesthesia versus the pre-procedural ultrasound guided spinal anesthesia, and we intended to do this in our study. And we compared the efficacy of both of them in terms of number of attempts. This is defined as the number of times the spinal anesthesia is withdrawn from the skin and reinserted. The number of passes, that is defined as the number of forwarding advancement of the spinal needle in a given intraspinal space, and the time taken for a successful lumbar puncture, which was defined as evidence of spinal fluid at the hub of the needle. As a secondary outcomes, we identify the median time for identifying the space and the median time to achieve a successful analgesia. After the adequate approval of Institutional Ethical Committee, 100 subjects were selected for the study, of which we lost 20 of them for various reasons. And the inclusion criteria included all the procedures which are going to be done in 18 to 85-year age group below the level of umbilicus. Exclusion criteria included pregnancy, coagulopathies, and refusal to undergo spinal anesthesia. All the procedures were done by anesthesiologists who had adequate training and been doing ultrasound guided procedures for the past 10 years or so. And 25 scout scans were performed on a healthy individual before performing the patients on a study group. Now in the PUS group, the ultrasound was used to identify the L3, L4, L4, L5 intraspinal space with the best image of the anterior complex, that is a ligamentum femur dura complex, and the posterior complex, that is a posterior longitudinal ligament, being in the parasagittal view. At these selected interspaces, the probe was positioned to obtain a clear ultrasound image, after which a skin marker was used to mark the midpoint along the long border of the probe and the midpoints along the short border of the probe. In the real-time ultrasound group, L3, L4, L4, L5 intraspinal space were identified by using the real-time images or in the parasagittal oblique view, and the needle was visualized breaching into the spinal space. Now, the study evaluated the variables and or their mean values and determined whether the statistically significant in order to predict the efficacy of two modalities which were used to do the spinal anesthesia in obese patients. A null hypothesis of no change in both the modalities of spinal anesthesia was assumed. Based on a pilot study, a difference of 20% in the primary outcome of the study of the two groups was hypothesized. Using this, a power calculation was done which showed a sample size of 40 in each group, an alpha of 0.05, a beta of 0.3, a power of 0.8, and a confidence level of 95% with a study population of 100. A Matt-Whitney U test and chi-square test were used to evaluate the statistical significance. Now the results I will not confuse with bar diagrams and bar charts. The age, the sex, and the BMI were comparable in both the groups and statistically not significant. However, the number of attempts, number of passes, and time taken to identify the space was statistically significantly less in the real-time ultrasound group in our study. Similarly, the success rate and conversion to GA were comparable in both the groups. However, the time taken to establish a successful lumbar block, successful analgesia, and the successful dural puncture on the first needle after 1, 5, or 7 needle passes was statistically significant, lesser in comparison to pre-procedural group in the real-time ultrasound group. Now, although pre-procedural is an established practice in the current form, the real-time US ultrasound acquisition of spinal needle appears to be much more better and safer and a faster alternative, especially in obese individuals, which has been demonstrated in our study as the time to identify was significantly less, almost half in comparison to the pre-procedural group. In comparison to the other studies which was done, which were prospective observational studies and did not compare with the pre-procedural group, we had some variations in the real-time ultrasound group. But this is basically because of different population, observer dependent and different approach. They used paramedian, we used parasagittal oblique, and a different age group. As the learning curve for this is concerned, only one study has been done. We did not took this as a part of our study. One study which said the overall identification accuracy of rate of ultrasound is 68%. That is pretty decent. On conclusion, real-time ultrasound sonography is here to stay as a useful adjunct for spinal anesthesia, and its introduction into the clinical practice will ensure a faster and a better alternative in comparison to pre-procedural ultrasound. Thank you.
Hello, Dr. Ravi.
Sir.
You're
Good morning,
practicing
sir.
in Oman. Good morning, sir. You're practicing in Oman.
Sir, I have just come to Oman. Before this, I was in India only, sir. I was at Command Hospital, Bangalore. This study was done at Command Hospital, Bangalore, sir.
Oh, so when you made a presentation, I thought you were taking from Oman, and your study has been done there. Because in India, this is a freelance practitioner session. So I was wondering, someone from Oman is talking in a freelance session. It was little confusing me. Could you clarify? I feel you should not have shown that slide of Oman, because it confused the whole thing. This is a private practitioners forum.
Sir, this was my practice when I was in India, sir. The study was done in India, sir.
Okay, now you're shifted there and you're practicing there.
Yes, sir.
Okay, so preoperative, you routinely follow this for almost all patients now in your practice?
Yes, sir. We were doing a lot of pre-procedural, sir. After this study, we have been doing real-time ultrasound, sir. And we have found it to be very, very useful, sir. And it's easier, sir. Actually, it's like the number of the more number, as you know, sir, you are too experienced. The more ultrasound probes you hold, the better you become. And after some time, the time taken to give a spinal reduces, sir, especially in obese people, sir.
So
and but sir, conventional, we still do conventional also, because we cannot forget the conventional modalities. So especially for obese people, we are using it, sir. For normal people, we do conventional technique only, sir.
But your patient have to pay for the extra charges that it comes forward with?
So we didn't take any extra charges, sir.
Okay, you have in-house sonography in your hospital itself.
Yes, sir. Yes, sir. Sonography is there in the hospital, so we didn't take any extra charges for the sonography.
Because in freelance practice, cost becomes a very important thing. And it's very always difficult to, convince the patient to do a pre-op screening just for seeing that how easy it will be to give this spinal or whatever. Thank you.
I completely agree with you, sir.
You have studied in a BMR of more than 30. Do you think BMR of more than 30, you really say them the obese? For the spinal, particularly?
Yes, sir. Actually, sir, we wanted a study population of around about, when we did the pilot study and calculated the power of study, we wanted a study population of a minimum of 100 patients, sir. So for that, we reduced the, initially we tried to keep the BMI at 35, but later on when we found out in the study, sir, our BMI was 34.9 in both the groups, roughly 34, 35.
Is fine.
But, yes.
Yeah, for the learning curve also, you need some normal patient.
Yes, sir. So, and we initially did with less obese patients, sir, who were 32, 31, 32. And then as we gained confidence, sir, we started increasing the BMI, sir.
Right. Thank you.
Thank you, sir. Thank you very much.
Thank you.
We'll go for the next.
Good morning, everyone. I'm Dr. Chaitanya Pratyusha from Nizam's Institute of Medical Sciences. My topic is dynamometer-based hand grip strength as a clinical tool for objective assessment of post-operative residual muscle weakness. Introduction. Post-operative residual neuromuscular block continues to be a significant post-operative complication with an incidence of 10 to 40%. An emphasis has been placed on monitoring TOF ratio to greater than 0.9 before extubation to ensure airway protection. However, there is a possibility of neuromuscular block that is not detected by TOF and can cause post-operative respiratory dysfunction. Aim to evaluate the role of objective assessment of hand grip strength using a handheld dynamometer to identify post-operative residual muscle weakness. Primary objective to assess post-operative residual muscle weakness using dynamometer in patients after complete recovery of TOF by comparing immediate post-operative values with pre-operative baseline value. Secondary objective to determine time to recovery to baseline muscle strength and to correlate the changes in the muscle strength with respiratory function using peak expiratory flow rate. Methodology. This is a monocentric prospective observational study. Inclusion criteria being ASA 1 and 2, surgeries under general anesthesia and age 18 to 60 years. Exclusion criteria, surgery or fracture or deformity involving the dominant upper limb, pre-existing neuromuscular or pulmonary diseases. Our sample size has come to 50 based on a pilot study where we have taken confidence interval of 95% and an alpha error of 5% and a standard deviation of 0.036 was obtained. Our study is registered under CTRI. A demonstration was given to all patients on use of dynamometer and peak expiratory flow meter. Baseline values for hand grip strength and PEFR were taken before induction of anesthesia. Standard anesthesia protocols were followed, and patients were extubated when TOF was more than 0.9 and clinical criteria for motor power recovery was satisfied. The parameters were again measured at 15 minutes intervals post-extubation until 1 hour, 30 minutes until 4 hours, and hourly until 6 hours post-operatively. Statistical analysis was done using SPSS version 21. Data was expressed as mean and standard deviation. Paired t-test was used for comparison of baseline muscle strength and PEFR with the parameters at different time points. Pearson correlation test was applied to assess an association between muscle strength and PEFR. Results, demographic data, average age was 25.9 years, female were 19 and male were 31, average BMI of 23.6, duration of anesthesia 240 minutes. Major portion of our patients underwent surgeries for trauma such as compound fractures and crush injuries. The other surgeries being free flaps 24%, peripheral tumors 20%, postbone contractures 10%. Comparison of muscle strength with time. 15 minutes post-extubation, muscle strength was only 57% of baseline value, and it continued to remain statistically significantly below baseline until 150 minutes. It was 50 to 60% of baseline at 15 minutes, 75% at 45 minutes, and it reached 100% only at 210 minutes after extubation. Comparison of PEFR with time. 15 minutes post-extubation, it was 59% of baseline. It continued to remain statistically significantly lower than baseline until 180 minutes. It was 50 to 60% of baseline at 15 minutes, 75% of baseline at 60 minutes, and reached 100% of baseline only at 180 minutes after extubation. Pearson correlation test has given a positive correlation between muscle strength using dynamometer and PEFR with a p-value of 0.86, and scatter diagram shows a linear pattern. Coming to discussion, superiority of objective measures of residual weakness over subjective assessment has been established in literature. Our study has emphasized the importance of dynamometer as an objective measure of residual weakness. In a study by Capron et al., a TOF ratio of 0.9 and 1 corresponded to a negative predictive value of residual muscle paralysis of only 40% and 77%, implying residual muscle paralysis cannot be excluded even after TOF ratio reaches unity. In another study by Dacking et al., a correlation between TOF and hand grip strength was established, and they concluded hand grip strength as an additional measure of post-op residual weakness. However, this study differs from our study in that it did not assess hand grip strength after TOF reached 1, which was the main objective in our study. In our study, PEFR also remained below baseline for 180 minutes post-extubation, thereby giving the impact of residual muscle weakness on respiratory function. Eicherman et al. Compared respiratory function in terms of spirometric measurements with acceleromyographic readings and concluded that although TOF reached unity, there was a prediction of high probability of adequate recovery from neuromuscular blockade, but respiratory function can still be impaired. These findings are similar to our study results. We have chosen PEFR as a measure of respiratory function as it is less cumbersome compared to spirometry. And in another study by Eicherman et al. On healthy volunteers, though the muscle strength was to such a degree that it caused insufficient to evoke respiratory symptoms, however, it could impair upper airway function, cause dysphagia, and decreased inspiratory airflow and complications such as aspiration. Therefore, assessment of muscle strength using dynamometer may be helpful in planning interventions to support respiration and thereby prevent post-op complications, especially in the high-risk population. Limitations of our study: it did not include high-risk patients with respect to pre-existing respiratory illness or neuromuscular weakness. Future scope: studies to evaluate residual muscle weakness measured using dynamometer in patients with pre-existing respiratory compromise and correlating with its impact on post-operative respiratory compromise can contribute to decreasing post-op respiratory complications. Routine assessment of muscle strength using dynamometer may be helpful in planning interventions to support respiration. To conclude, a significant reduction in post-op muscle strength was detected using dynamometer to objectively measure hand grip strength even when TOF has returned to unity and even when there are no clinical signs of muscle weakness. Objective assessment of muscle grip strength using force dynamometer can be a new metric to monitor post-operative muscle weakness. Residual muscle weakness is significant enough to affect peak expiratory flow rate in the post-operative period. These are my references. Thank you.
Madam, this was something, a different type of study. I would appreciate.
Yes, sir. Thank you, sir. Morning, sir.
Morning. What made you think of using meter?
Hello, sir.
Yeah. From that, you get the idea.
Sir, the idea came from the point that some of the patients, especially the high-risk group, they were experiencing some amount of respiratory weakness even after TOF reached 0.9. When we followed the criteria of 0.9 for TOF for extubation, even then some of the high-risk patients were having some amount of respiratory weakness. So we wanted to just check it in a normal patient population.
So is dynamometer commercially used always? Is it better than TUF? That's what I'm trying to suggest.
Sir, actually, the main advantage is TOF. After the patient awakens, TOF is causing some amount of discomfort because of the muscle twitches. Whereas with handheld dynamometer, it is simple and patient is comfortable, sir. And the cost is also it costed around 7,000 for us, sir. The dynamometer, so it can be used in the post.
What made you think? Why did the idea come of using a dynamometer? I don't think it has been used in mentioned in anesthesia books, is it?
Yes, sir. The point was we wanted some measure to assess the muscle strength. That was comfortable for the patient without any discomfort after the patient wakes up. So from that we chose dynamometer, sir.
Okay, the concept was good, but I feel at the end of the session, I would like to comment a little bit on the presentations that you all have been doing for all the 8 speakers. Yes. So over to Arvind, sir.
Okay. I have a couple of things to ask. Do you think it is all the time it is the weakness because of the muscle relaxant only?
May not be all the time, sir, but the most probable reason post anesthesia muscle weakness comparing to baseline could be because of muscle relaxant, sir. And in this study, we have selected only peripheral surgeries, sir, on the limbs. We didn't include any abdominal surgeries where the pain could have caused decreased effort on breathing. Only peripheral surgeries were chosen, sir. So most probably the reason could have been muscle weakness.
Second, now yes, with almost with a new Canadian study, even 0.9 TOF is not sufficient.
Yes.
So one has to see the equal. And second, even yes, after equal, they recommend to even reverse fully.
Yes, sir. Actually, when our extubation criteria was mainly based on clinical assessment, sir. We used TOF only.
What was your TOF ratio when you extubated the patient?
Actually, we monitored TOF until it came to 0.9, sir. Later on, we followed clinical criteria for extubation, sir. We didn't depend on TOF ratio.
The 0.9, you have a weakness.
Yes, sir.
Right? So, yes, the newer criteria to extubate is 1 only, equal TOF.
Clinical criteria was more given more importance, sir.
No, not a clinical guy, but TOF should be 1. That is what I'm saying.
Okay.
It's not 0.9. It should be the equal, all 4. Okay. That is one thing. Another thing, what I personally feel, most of the patient in post-operative period with multiplicity of the drugs.
Yes.
There is a central depression as well as there is a muscle weakness. There are so many things which we don't know about, some electrolyte disturbances and other things. So you may not have a proper power of the small muscle. Small muscle will not be having much of a problem.
Sir, in this study, we have chosen only those patients who are ASA 1 and 2 without any disturbances, and only after they have completely awakened, 15 minutes post extubation, we have taken the reading, sir. Almost all the patients have completely recovered from anesthetic drugs, sir, sedatives.
Have you used any parameter to monitor the level of consciousness or sedation level or something like that?
We didn't use any parameter in particular.
Do you think it is clinically problematic for the patients?
Sir, that is what I wanted to say is in our patient population, none of the patients complained of any specific muscle weakness. Only with dynamometer we could assess. But in high risk patient group,
is there any clinical significance?
In high risk, what I want to emphasize is in high risk patient group, this small amount of respiratory muscle weakness could cause clinical impact, sir. Because our patient group was not a high risk group, we didn't see any clinical impact, but that small degree of weakness is sufficient to cause clinical impact in high risk population is what I wanted to highlight, sir.
So high risk patient has a multiple reason to have a weakness for the muscles.
Yes, that's true.
Right from the septicemic muscles to nutritional problem to the strength of the things, and all other parameters.
And
so, otherwise also without having, even without doing not using the muscle relaxant, you need some support.
Yes, sir. And additionally, our muscle relaxant effect can add to the weaknesses. What you want to highlight.
Okay, fine. Thank you.
Yes, thank you, sir.
Sir, can I play the next video?
Please go ahead.
I think this is last and it.
Yes, last.
Yes, sir.
I'm Dr. Atul Gandhi, consultant anesthesiologist doing private practice in Ahmedabad since 26 years. I had done 30 case study of awake fiber optic intubation in pediatric patients of TMJ ankylogenesis. Introduction: securing the airway is a fundamental to pediatric anesthesia. Endotracheal intubation in TMJ ankylogenesis patients considered as a difficult airway management. Fiber optic intubation is gold standard for TMJ ankylogenesis. This is a number of cases who had congenital fiber of TMJ ankylogenesis or as a maybe trauma. I have more than 10 patients who had history of trauma before 5 to 10 years and TMJ ankylogenesis developed. Our aim is to see the effectiveness of fiber optic intubation for difficult airway management of TMJ ankylogenesis in pediatric patients while maintaining a spontaneous ventilation in awake patients. For evaluation of anesthetic management and its complication, I had observed. I had done 30 cases with radiographically and clinically confirmed TMJ ankylogenesis. About this, 5 to 7 years of age of 8 patients, 8 to 10 years 18 patients, and 10 to 14 years 4 patients. Routine airway assessment was done with standard proforma, including the Lehman, look externally, Mallampatti classification, obstruction airway, neck mobility, and awake fiber optic intubation done after local blocks. The preoperative difficulty assessment and postoperative outcome was recorded. As a routine, as a basic requirement, all resuscitation equipment like oxygen, mask, laryngoscope, ambu bag, endotracheal tube, emergency drugs, suction catheter, tracheostomy will kept ready. Preparation of the patients, preparing the patients mentally for procedure and explaining the procedure to the child and also the parents. And this is the most crucial part, to explain the patient for cooperation. Oxygen supplementation during the procedure is mandatory. We had given nasopharyngeal prong through the nostril. The patient should be placed on supine position on table. In younger children, it is helpful to swaddle the arm in a seat and leave the chest free for obstruction, observation, and auscultation. Routine monitor applied like ECG, SpO2, NIBP, etc. Total supine position is most comfortable and most patients for nasal insertion. This is I explained it to the patient. Okay. Follow. Now check the nasal frequency. श्वास ले मोबाइल में श्वास ले सही छोड़ दे ले श्वास छोड़ दे ओके अपोजिशन कर दे પછી તમારે મુશ્કેલ નહીં કરવું Perform the mask injection maintaining the spontaneous ventilation. Start IV and give injection glycopyrrole 0.02 mg per kg for excessive salivation. Spray 2% lignocaine in the both the nets. Mask ventilate with the patient to distribute the lignocaine distally. Pass red rubber catheter in the both nets to check the patency. A transtracheal block were given 1 cc of 2% xylocaine intrathecally. 10% lignocaine solution sprayed who had 10 to 10 mm mouth opening if it is possible. Choose more patent nostril for fiber optic scope. Keep the oxygen catheter in other nostril. This is how I have given the local blocks. Now, procedure for the bronchoscopy. Bronchoscope should be held straight without any curve. Maintain the routine along with the midline. Identify the landmarks such as uvula, back of tongue, epiglottis, light cable, and suction channel on the left side. In this insertion of endotracheal tube, first pass the proper size of endotracheal tube through the nostril and then pass the fiber optic bronchoscope through the tube and then withdraw the endotracheal tube from the nostril. This is because of the prevention of the damage of the scope. As such, the pediatric bronchoscope, which I have, is very small diameter and likely to be damaged directly we go through the nostril. So as it is entered the oropharynx, tube usually pointed straight at the glottis. If any difficulty in visualizing the code, then extend the head, apply jaw thrust or pull the trunk forward. Tip of the scope is gently negotiated and introduced into the trachea. Fibroscope pass into the mid trachea. Endotracheal tube can be easily pushed over the fibroscope into the trachea to a position 2 to 3 cm above the carina. Gradually remove the scope continuous vision. This is how we can pass the endotracheal tube and then to the scope. If tracheal lines cannot be identified, the fibroscope should be advanced till the carina visualized. Presence of the tracheal bifurcation will confirm the tracheal intubation. Proper placement should be clinically confirmed by auscultation of apical and mid-axillary for bilaterally equally air entry. Looking for symmetry, bilateral movement for upper chest wall. End-tidal CO2 is reliable for confirming the tube placement. Result, awake fiber optic intubation were done in 30 patients, out of which 1 patient had to undergo tracheostomy and 2 patients were postponed for 2 weeks. And after 2 weeks, those 2 patients were successfully intubated. Fiber optic intubation is the gold standard for intubation in case of TMJ and colloids. Non-availability suitable size of fiber optic bronchoscope makes management more difficult. We have done awake fiber optic intubation after proper explaining the patient and parents for cooperation. Expertise for the operator is necessary. Blind nasal intubation is associated with the more complication and success is less compared to the fiber optic. Conclusion, awake fiber optic intubation is less time consuming, safer with higher success rate, is associated with the reduced morbidity. Awake fiber optic intubation with the topical anesthesia solely might be superior alternative in an effort to reduce the risk of aspiration, airway compromise, inadequate ventilation, hypoxemia, and apnea associated with the sedation and or general anesthesia. Our 29 patients were managed well by transtracheal block and nasal spray. In 1 patient, after second attempt, due to the non-cooperation and bleeding, elective tracheostomy were done. Thank you.
Hello. Yeah, Dr. Atul. Good morning, Dr. Atul. did you
Hello.
pre-medication or any sedation to all this? Did you give any sedation, TIVA or any sort of anesthesia to patients?
No, sir. In the private sector, I had attached with the dental hospital honorary. I had not given not a sedation at all. I explained the patient properly, and two residents is there. Some little bit movement is there, but in one case I used fentanyl. Up to 12 years age boy, I had given fentanyl after the second attempt.
And you intubated all the patients in the operation theater or outside the operation theater? Because I saw you in regular dress without your OT clothes on or even a mask.
Yeah.
How safe is it doing all that?
Sorry, it's just before the OT, I had given this pre-operative room in that setup there. And then they shift to the operation theater.
But
So
then
I
you don't,
visited only,
you were in your regular home
only
clothes, not in OT dress.
yes, same. But I'm just basically I'm private practitioner. I'm visiting this honorary visiting in dental hospital.
Yes.
They have a pre-operative room. I then send them and then intubate that patient and then leave the hospital. So anesthesia management is a different. I just intubate the patient. Before that, they give tracheostomy in each patient. So they will ask me to intubate the patient. I have
So
a fiber optic orifice 3.2 mm diameter.
So you are called by the anesthetist to intubate these patients?
No, they gave me appointed as an honorary associate professor for only for intubation.
Okay. Hello.
Yes, sir.
Yeah.
I visited only for intubation in the patient. And then anesthesia will give the civil staff, civil hospital.
Oh, so you're just intubating the patient and there's no anesthetist managing the patient?
Pardon, sir?
There is no anesthetist managing the patient after you intubate and go?
Their whole team is there, sir. Assistant professor is there, two residents of anesthesia. Basically, Ahmedabad Dental Hospital is attached with this Ahmedabad Civil Hospital. I think Dr. Sailesh is the HOD of the department. They are officially appointed as a dental hospital in rotation wise. I visited just for intubation only. So they are moving there. After intubation, I will hand over this patient.
So Atul is a bronchoscopist, basically.
Okay. Practicing as a bronchoscopist instead of being an anesthetist.
Yes, I just want to.
Okay.
Just previously they do number of cases in the tracheostomy only. They call ENT surgeons and they do the tracheostomy and then go for the management, anesthesia management.
Okay. Thank you. Thank you.
Good, Atul.
Thank you, sir.
Thank you.
Thank you, sir. Sir, one month again, fiber optic pediatric and pediatric patients. I will try this, just explain the patient and then go for the intubation. Bronchoscopy they have suggested in under sevoflurane anesthesia, but after giving the inhalation agent, the difficulty for intubation with fiber optic bronchoscope is more because of muscle relaxation and trachea. There's a less movement is there. So I use awake fiber optics and okay. Thank you, sir.
I feel this was the last speaker, right?
Yes, sir.
Are all the speakers online?
We have 5.
Yes, you all are in one room.
We are in team with.
I wanted to.
Yes.
Yeah, great.
We are on.
I just wanted to discuss something about the presentations. I mean, I was not happy with the PPTs which are prepared by Dr. Tejas, Hetal, even yours, Atul, the one that lady, what's her name, Pratyusha. See, there are basic, whenever you make, time I'm just giving you a few hints. As far as possible, your PPTs should have maybe 6 to 8 lines. And the size of each letter should be at least 24. At least 24. Below that, it is not very legible. The colors that you use, like you used pink and white, so it is not very, even in a hall or on the computer. Black and white makes a very good effect. And the size, and Pratyusha was just reading the whole presentation, which I feel never write down the whole lines. Just write down tips so that you get it. It's always making an effective presentation itself is a very big talk. But I thought just because we have a few minutes, I thought I'll just give some tips that your presentation should be definitely good. Dr. Mangal Deve rightly used videos because he made his message very clear. So this is let this be a learning phase for at least 4 or 5 names that I took. I thought the presentation, the PPTs were not up to we are in a national conference, so let's improve our presentation skills. Making good PPTs is half the work done. If your PPT is good, your presentation automatically becomes much better. But otherwise, I feel it was quite interesting sessions. And I feel privileged to go through all of you and listening to all some of you I've seen here and there. And I feel it was a good interactive session. I'm sure Arvind Bhai sir make his last use.
Thank you.
Okay.
Thank you very much. Thank you.
Thank you.
Next
Thank
time
you
we
very
will
much.
take your point and improve on this.
Yeah, please. Arvind sir.
Yeah, have a nice day.
Dr.
Good
Arvind.
that at least in a busy schedule you are presenting something.
Yeah. No, the good topics, interesting topics. I was very impressed when I had gone through these topics before, and I feel it's good. I mean, India is improving a lot. During our time we didn't have so much of opportunities to present, but these days are the opportunities, so it's good you all are taking advantage of that fact. Good. I feel we can conclude this session. The organizers can probably give a yes, Atul.
Yes, sir. Now I'm from the core team firm. So conference is now as excellent physical and virtual both part. Thank you very much. You are supporting. But physically also we are present. Number of patients, the number of delegates is there. 1,600 delegates physically reported. So it's I think we saw the successfully event is not going smooth.
Yeah, that's
you
very
all
good.
Support.
Thank you. We are always there. But I'm missing being in Ahmedabad. I was desperate to come, but then I have a marriage in the families. Daughter is getting married, so it's like
Yes.
that way.
Yes, sir. We have difficulty for managing this hall because of the number of marriages is there. So luckily there's a new hall that then we give opportunity within short time. 2 months we booked this hall. We had shipped the venue from Mahatma Mandir to the here.
Right.
Thank you very much, sir. Thank you.
Thank you. Thanks a lot.
Thank you.
Thank you.
Thank you.
Thank you.
Bye.
Thank you.
Bye.
Thank you. Bye bye. हाँ बोलो सर
बेटा निकल रहे
हाँ ये चालू से सेशन
Anybody from the tech team?
Yes, sir.
So the last session is over.
Yes, sir.
So we'll be heading towards the Yuva session now, is it?
Yes, sir. Yes, sir.
Welcome to the
Good morning, everyone. Now we are going to start our next session, your ISA session.
welcome to the Yuva ISA session. I hope my audio and video are clear. Can somebody tech team confirm?
Yes, sir.
Okay, great. So welcome to the Yuva ISA session, and this program of Indian Society of Anesthesiologists has been launched to promote the Yuva ISANs, that is Indian Society of Anesthesiologists members who are less than 40 years of age or within 10 years of their post-graduation, especially focusing on postgraduates, senior residents, and younger faculty. It started in 2019, and we had different programs which are going under this particular subset of UIS's program of Indian Society of Anesthesiologists. So we'll discuss this in due course of time, and I welcome Dr. Amit Kohli, who shall be coordinating this session, and to introduce and carry forward.
Thank you, sir. Am I audible, tech team? Tech team, I am audible?
Yes, sir. Yes, sir. Yes, sir.
Tech team, can you please confirm, am I audible?
Yes, sir. You are audible.
Yeah. Good morning, everybody. This is a lovely morning, and thank you very much, Naveen sir. But as you told, this is a very good platform for our young budding anesthesiologists, to interact with the senior faculties and the office bearers. This session has specifically been kept, right? So as an icebreaker kind of a thing, right? Because there is always an hesitation asking questions from the senior office bearer. We have, as we all know, we have Naveen sir with us. And our young Yuva anesthesiologists, they are joining one by one, and there have been questions which has come to ISA national headquarters. Many of them are not able to join today, right? But we have questions compiled from across the nation, and we'll take them one by one, right? Firstly, we have Naveen sir, we have a query from our one young anesthesiologist, that is Dr. Shweta Jaju. She's from Kalyan. She wanted to ask that what does it make any difference in my professional life if I being a member of an ISA as compared to not being a member of ISA? So this is the question of most of our, budding anesthesiologists. That what benefits do we have by joining the society?
Amit and all my dear friends, I can say that in my capacity as National Secretary of Indian Society of Anesthesiologists, that there are numerous advantages of being a member of the society. I am happy to share with you that right now we are 36,002 members of Indian Society of Anesthesiologists. And the most important benefit is that everybody in India comes to know that there is an XYZ doctor in this particular city who is pursuing MD anesthesia, diploma anesthesia, or DNB anesthesia course, or is a qualified specialist. So sort of your registry comes. 1. 2, you are able to coordinate with all other peers, friends in your own city, in your own branch, and you can discuss these forums, clinical discussions, academic discussions, research discussions, and even you can have your social get-togethers, help from each other in difficult cases, and some sort of peer pressure also of future advancements and career advancements. Also, if you're a member of ISA, for attending the conferences, you get a 50% rebate. You get a Indian Journal of Anesthesia subscription free for life, because our ISA membership is for life. There are no annual charges or no 10-year charges or 5-year charges. You are entitled to take a family benevolent fund scheme, which is our social protective scheme. Then you can compete in all sort of presentations, award categories. There are numerous paper presentations and award categories, especially for younger also. You can present your paper, poster, fine, but you can also compete also. Like for younger lot, we have got Trainee Talent Award for postgraduates, Dr. B.B. Mishra Memorial Young Anesthesiologist Award, Dr. M.T. Bhatia Young Pain Physician Award. Then there are award categories, COPS Award in categories of cardiac anesthesia, neuroanesthesia, pain, clinical pharmacology, private practitioners, transplant, and 8 categories there. Obstetric anesthesia, pediatric and neonatal anesthesia. Also, if there are some medical legal issues or there are some professional indemnity issues, you got ISA endorsed professional indemnity scheme also, which helps you into your day-to-day practice life. You can participate in ISA Art and Literary Club, ISA Cultural Club, ISA Social Outreach Program, do social programs under the banner of ISA. You can participate in resuscitation activities under the banner of Indian Resuscitation Council. You can have the benefit of ISA Financial Advisor, how to have a second source of legal income. You can get involved in innovation session, new innovations which are done day in, day out. You can be guided for how to get patents for them. Also, you can join the ISA Sports Club, ISA Fit Anesthesiologist campaign. You can participate in formation of guidelines also, those of you who are consultants, in ISA Guidelines Committee. And you are entitled to all sort of academic activities, whether it is ISA sponsored CMEs, workshops, conferences, ISA online PG classes. That has also been actually done for those you ISANs. ISA online PG classes are held every Monday from 4 to 5:30 p.m. on virtual platform. So these are some of the advantages, I can say many advantages of taking the membership of prestigious Indian Society of Anesthesiologists, which is a universal platform for Indian anesthesiologists, and life membership fee is only 8,500, and it is all online and virtual thing.
Thank you so much, sir. I believe those Yuva anesthesiologists who listen to us today, that they are encouraged by sir's golden words, that kind of a thing. There is so much the society is offering them, right? And there's a lot of not only the academic support, there's various other kinds of support which sir has mentioned, that which encourages our Yuva to join us in a brigade. Naveen sir, I'll start from there where you left. That ISA has a lot of programs, which has been initiated last year. One of them is the PG teaching classes training program, which is being held regularly and well attended by many of the young anesthesiologists throughout the nation. Sir, there is a question with us from Dr. Abhijit Kumar. He's from BMMC and Southern Hospital, New Delhi. Sir, his query was that this ISA is doing a lot for postgraduates like PG classes and so. So will there be any modification we are expecting in the curriculum so that there should be no gap throughout the nation? And one more thing, that exit exams, there may be different patterns everywhere or something. Should the ISA take up that matter, that it should be a uniformity throughout the nation? Are we working somewhere on that, the uniformity in the curriculum and the exit exam?
Yeah. Amit and Abhijit is also live. So it's a pertinent question that having ISA online PG classes, the main aim of starting these classes were with this aim only, that uniform postgraduate curriculum across the country. This is the minimum level of education, knowledge, and subsequently we are working on ISA skill centers also, minimum level of skills, which all anesthesiologists should possess all across the country. That is so that there is a standardization. Also, examination pattern is different, timings are different in different parts of the country. So once our education standard is there, we are on the process. It's a Herculean task of designing ISA online mock elections. So we have been so far successful in devising how will we conduct a theory exam, but practical exam, doing it on online platform, we are devising this modality, and I'll like to have young ones who will guide us how to do online practical examinations also. So the aim was starting this ISA online PG classes, which are held on Zoom platform, live stream on ISA YouTube channel, ISA NHQ, and all the videos are available on ISA website also under the tab of ISA academics. Their classes are available. So aim is definitely to have uniform PG curriculum across the country. We're also working on uniform UG curriculum also, and so that same level of teaching is there across the country for undergraduates also. And we're working on ISA online mock elections at the national level.
So much, sir. And Dr. Abhijit, any further query which you have in your mind?
Thank you so much, sir. One more thing to add up, as you have rightly said, that creating online practical exam is a Herculean task. But as we all have, the residents have passed the MD exams, should there be more skill-based assessment in the final exit exam? Like our knowledge is being judged, but should our skills also being judged? Because we are in such a branch where our skills also matter for optimum patient care.
Abhijit, the examination pattern needs to be redefined. Examination pattern needs to be redefined because it's, yes, most of a standardized things going on, but yes, now it is coming more of objective type and clinical oriented, but still we are following four or three papers and 10 short notes, 10 marks each, and subsequently a single day examination of long case, 2 short cases, and table viva, equipments and drugs and ECGs and spots. But yes, it has to be more objective ways. And in COVID, it was done actually, to be honest, by majority of the institutes, because you cannot examine the patients directly. There were clinical scenarios which were created. Number of patients coming admitted in the hospital were less, and we were all busy with our COVID work also. Yes, restructuring is required. I can take up with the ISC HOD club, because where all the HODs of the different departments are there. We can suggest, formulate some guidelines and suggest it to the NMC also, or our own universities also. But yes, I must at this point salute all the postgraduates all across the country of anesthesiology. You have been the year 2020, I always say, and 2021 in this COVID pandemic will be remembered for the year of anesthesiology residents, who have shown that their bodies are made up of metal and nerves are made up of steel while they have been working in COVID ICUs. So salutes to you.
Thank you so much, sir. Thank you so much.
Thank you so much, sir, for word of encouragement for all residents. Thank you so much, Dr. Abhijit, for joining us today morning. I know you have another session waiting for you within a couple of minutes only, right? That is there. So whenever you feel like you can leave the session, you're most welcome to do so.
Thank you so much, sir.
Naveen sir, we have Dr. Kamna Kakkar today with us. She's from Rohtak itself, right? And Dr. Kamna has a very pertinent question in today's word that
is live.
Kamna is live. Kamna, you can ask your question directly.
Good morning, sir. Good morning, all seniors. Sir, I wanted to ask a question that the whole world is talking about Black Lives Matter and Me Too movements. How do you think that our Indian Society of Anesthesiology can help in creating and sustaining diversity, inclusion, and equity at workplace, so that we can discourage discrimination in terms of race, caste, religion, sexual preferences, political preferences, so that discrimination that is inflicted upon patients by our physicians, by our doctors, and also upon fellow doctors by doctors, that can be discouraged?
Amna, this is a very sensitive question you have put forward, and I'll ask back to you. Do you think such a problem is existing in different departments, in different universities, in different departments of anesthesia?
Definitely, sir. That is why I put forward this question. Because, sir, recently we had a patient in our ICU. She was a transgender patient, and all our nurses, they just refused to catheterize the patient just because they said, we are not aware how to catheterize a transgender patient. And that was really, embarrassing for the patient, and as well as for me being the treating doctor, that our nurses were feeling incapable of catheterizing a transgender patient. So that's why, sir, I put forward this question that don't you think that our training should be more gender sensitive, more sensitive in terms of our, like we shouldn't inflict our own political, our own prejudices towards our patients, towards people who come to seek help in hospitals. They are here to seek our help, but we are inflicting our own prejudices towards them.
Kamna, I 100% agree with you that this is our medical ethics also, to treat all patients, all races, all castes of any political affiliation. He is patient for us, to treat them nicely. And this transgender, male, female, all deserve equal respect. And that has to be inculcated in our staff who are treating the patients. I agree with you that. But as far as my knowledge goes, working in OTs, working in anesthesia department, usually such biases in anesthesia profession, I think, I personally feel the Department of Anesthesia across the country, they have got good bona fide, and 60 to 70% anesthesiologists are females only, kind-hearted, and who just take care of the whole department, and things move in a cohesive manner. So definitely, if there are certain issues which are brought to our notice, that there is some discrimination, because if I'm a teacher, for me, all postgraduates, all younger consultants are equal. Yes, I may like one or two, that is a different thing, but it does not mean that one A will be taught less and B will be taught more. Teaching, training will be equal. And in anesthesia, you will also understand that there is ample opportunity to work. You can work 24 hours and still patient load will be there. So, but if you have got some suggestions, ISS should do this on this subject can get 1, 2, 3, so they are most welcome. But I'm really happy that you had brought up such a sensitive issue, and we need to look into it. But I welcome your suggestions, please.
Sir, I was recently a part of an event where there were various people who presented their presentations about words that are, that should be prohibited from being used. For example, there was a word called like blacklist. So blacklist is a word that shouldn't be used. Instead, words like, prohibited list should be used, because black and list shouldn't go together, because black is, like Black Lives Matter say, sir, there have been various words, various phrases that have been highlighted, that these are some kind of words that should be not used in workplace, because these words create discrimination. So, sir, various classes should be held so that everybody is sensitized towards things that are not appropriate to be used at workplace, words that are not appropriate to be used at workplace. So I think, sir, sensitization classes should be held, and plus, sir, all staff members should be taught how to deal with patients who are not from, who are like transgenders, patients who are not coming forward to, there are patients who don't come forward to take treatment because they are not comfortable sharing their preferences with their doctors. So I think, sir, sensitization classes, gender sensitization classes, religion sensitization classes, these all should be held, sir, by ISA regularly at national level.
Your point is well taken and noted. Definitely, one of the future classes on the ISA online PG classes will be on this sensitive topic. And I take this opportunity to invite you also to that particular class and be part of the discussion. Thank you, Kamna, for bringing up such a nice and sensitive issue. Thank you very much.
And giving us a very valid track, right, to think about. Next in line, sir, we have Dr. Kul Saurabh Kaushik. Dr. Kul Saurabh is working at Fortis Hospital, Escorts, New Delhi. Dr. Kul Saurabh, I feel you have one question for Naveen, sir.
Yes, sir. Good morning, Naveen, sir, and Amit, sir. Thank you for giving me this opportunity. And first of all, I would like to congratulate ISA and Naveen sir and team ISA for doing such a stupendous work even at the COVID times. And the PG classes have been arranged regularly, and few of the times I have also attended few of the interesting topics. Now, having said this, I would like to ask that does ISA provide any kind of scholarship, or is there any kind of provision for fellowship in either in India or abroad, or does there exist any kind of sponsorship for the research work, or kind of some kind of basically learning process, and what are the procedures to avail such kind of opportunities?
And thank you, Saurabh, for bringing up this question. And very happy to share with you that there are numerous fellowships courses going on. They are named as ISA, NEON, Inland and International Fellowships. So ISA, NEON, Inland Fellowship is basically for second and third year residents who are members of ISA. And I'm happy to share with you, now this exam will be held online on ISA app. Earlier, this exam used to be held at the national conference venue. Like today, we are at Ahmedabad. So the venue, people who are coming here, they used to appear in the exam. But now this exam will be held online, and the next exam will be held maybe in December, end of January, and it will be notified to all and on ISA website also. So it usually is a 45 minutes question paper, multiple choice. And earlier we used to give 15 fellowship, then subsequently we increased 25 fellowships. Now there are 40 fellowships across 10 centers across the country in different fields, whether it is cardiac, neuro, thoracic anesthesia, pediatric anesthesia, pain, USG guided blocks. So all this is done, and there is a financial grant of 25,000 to attend these courses for a week. And usually expenses are met because we advise the students to choose a center where you are, which is near to your place. We also have got ISA International Fellowship for the senior residents, and 2 of them with a financial grant of 1 lakh each. But because of COVID, last year and this year we are not pursuing that, and we have shifted that grant, that corpus amount, to the inland fellowship. Because by asking our residents to go abroad, there are so many quarantine issues, so many vaccine issues, and so we are holding on because of the COVID pandemic. Having said that, then we are coming up with ISA skill centers. This is basically two-way process. All hospitals across the country will be asked to get accredited with ISA in whichever clinical work they want to teach. Like somebody wants to run a course on fiber optic intubation or airway modalities, UAG guided blocks, pain procedures, basic, advanced, cardiac, neuro, like that. So this will be basically what an institute can offer in the least time that will be notified, probably at no cost, no benefit ratio. And the members will also tell us, suppose somebody who is living in Warangal, he wants to learn about iGel. So he will be able to search what are the centers in the Telangana which can teach me about iGel or fiber optic intubation and how many days it is required. You also know some procedures, advanced pain procedures will require 3-month fellowships, but some basic procedures can be learned in 2 to 3 days also, right? Depending upon the patient load. So we will act as a catalyst between the members and our ISA accredited clinical skill centers, so that members can learn what they want in the least possible time and without affecting their practice or study leaves like that. Research, we have got a research methodology module, IJA, ISA research methodology module. Those workshops are held regularly and it is done by Editor-in-Chief Dr. Lalit Mendiratta, Dr. Subinderjit Singh Bajwa. And you can learn about how to prepare your thesis work, how to print them, how to publish them, how to present a paper. All those things are included in those. So I think, Kulsar, I have been able to answer your queries.
Yes, sir. Thanks for inviting us.
Thank you so much, Dr. Kulsaurabh, for giving us a very stimulating topic for discussion. Right. Naveen sir, we have one question from Dr. Raghav Gupta. He is an onco-anesthesiologist at AIIMS, New Delhi. Right. Raghav wants to ask that in continuation with what you already told, that yes, there should be some centers, training centers at various parts of the nation for skill training, right? And that is there. So Raghav wants to ask, sir, is any plan of ISA to develop some standardized training modules for the procedures like CVP insertion, fiber optic, or any other skillful procedures, so that there should be uniformity all throughout in this online training modules? This is what Raghav wants to ask.
Yeah, with this only in mind, yesterday only in our GC and GB we approved the ISA skill centers, and absolutely on this particular thing. But what we discussed was that, see, online courses are available also and can be conducted under banner of ISA also. But we shall be motivating, in addition to the online, you are going to a particular hospital for learning a particular procedure. So that hospital itself teaches you basics in the online course, and then subsequently you do the clinical work. Rather than, see, you can also understand that seeing videos, reading books can orient you, but you need teachers to teach you, to train you. So orientation will be done by online classes and online modules. But hands-on is also very, very important. You will first observe, then perform under assistance, and then perform independently. I think then only you can learn about it. If you can, I think this is our plan.
so much, Naveen sir. I hope Dr. Raghav listening up from somewhere, the query is satisfied very nicely by sir. Right. So there's a lot of discussion so far. We have started the session about academics. Right now, one question from Dr. Amit Yadav. He is an anesthesia resident at SMS Medical College, Jaipur. Right? He said, okay, sir, after rather during the PG-ship or after doing PG-ship, many of them are posted in a district hospitals or a rural setups or something like that, where there is a certainly lack of infrastructure and even the basic infrastructure for our doctors or anesthesiologists to stay or getting the equipments or something. So is ISA doing it that district or rural level also something to support them?
I agree. Lots of institutes and hospitals are coming up at district level, new medical colleges also. And but they are equipped. But you're working in a rural area, a nursing home setup, doing practice. These are their challenges. And there our friends are working alone also. So there, I think even OT assistance is also less. What we can do is that we can provide a mechanism that they can procure some equipments. But since these involve finances, we can only be a guiding force to them. Okay, suppose somebody wants to have a video laryngoscope or an intubating LMA. So we can help them that, okay, these are the firms which you can, where these are the time-tested ones, these are the economical ones. And also, if suppose they want some sort of help, because OT assistant training is also being pursued, because we also wish that lots of OT anesthesia technicians should be trained so that they can offer assistance to our colleagues who are working individually in peripheries.
Thank you so much, sir, for touching upon a very relevant and sensitive topic. Right. I can see that we have Dr. Nikhil Ranjan with us. Dr. Nikhil is a senior resident in anesthesiology at GB Pant Hospital, New Delhi. Dr. Nikhil Ranjan, your query to sir.
Nikhil, your audio is not coming.
Yes, sir. Can you hear me now?
Yes, please go ahead.
Yes, sir. Good morning, Naveen, sir, and respected all other faculty members of ISA. Sir, I know few junior and senior residents who are under tremendous stress and even thinking about suicide and whatnot. So my question is that shouldn't ISA provide mental health resources like affordable and free access to psychiatrists and counselors to counter this mental health crisis that is taking over young physicians?
That's a very pertinent question, and Nilanjan and Nikhil, I'm happy to share with you that as a part of ISA Fit Anesthesiologist campaign, this program is already going on, in the sense that we're not focusing only on physical fitness, but on mental fitness also, and also working on drug dependency and drug abuse also. Right. So yes, we know that at times our residents can be under stress because of so many reasons, personal also and professional also, and they need some sort of counseling and some sort of mentorship also. So under ISA mentorship program also, we offer, yes, it has to be strengthened at grassroots level. It has been started at national level, but you are very right, it is still to be developed at a local branch level. Like suppose you are in Delhi is a big city, so there should be 5-6 such people who are available. Somebody can talk about physical fitness, somebody can talk about mental fitness and how to do counseling, and refer you to an appropriate for psychological counseling or evaluation. Because majority of the time, once your senior or your mentor, he talks to you, you feel more relaxed and you are more comfortable quickly also. But at the same time, I'll convey to you, through you, to all my dear postgraduates and senior residents, that if you're in problem, please discuss with your seniors. There may be problems with your seniors or with your peers also. Family issues, other issues can be there. There are so many issues which you keep it up into your heart. But please don't go for addiction or some use of drugs, abuse of drugs. Go for an counseling and healthy life. And there's a lot as an anesthesiologist to achieve in life. I can tell you, our specialty has advanced like anything, that you can pursue your career in general anesthesia, or you can become a super specialty in chronic pain, acute pain, regional anesthesia, cardiac anesthesia, neuro anesthesia, pediatric anesthesia, critical care, onco anesthesia, obstetric anesthesia, right? Obesity anesthesia. So many fields are developing. So have passion for your work, work hard, and success will be yours.
Thank you so much, sir.
Thank you, sir. Thank you, Dr. Nikhil, for joining us today.
Thank you.
Sir, we have another question from Dr. Karthik. Dr. Karthik is a resident doctor at Maulana Azad Medical College, New Delhi. And Dr. Karthik wants to ask, sir, there's a lot of study material these days available. There may be, other than textbooks, there's a lot of on the social media also, Google, medical journals, etc. So what should be for an anesthesia resident, should be a standard practice to what to follow?
This is a very pertinent question being faced not by residents, even by us also. So many medical literature is available on Google and WhatsApp, university. But my suggestion to all of you is, please don't go read the summary and conclusions only. Read the whole article, then you will come to know what standard it is and what are the hidden points written in it. And always see what it is rating, how many citations that particular article has got. Article which has been literature or evidence which has been published in a textbook carries much more meaning. But yes, there are recent advances which are published in a journal which has got a good indexing and impact factor. Rely on them. Just merely forwards from WhatsApp, you should just read it, but please always see the quality and rating of that article. Googling everything, Google can tell you all the informations, but Google does not tell the quality of information. So please rely more on your standard textbooks, standard international journals and Indian journals, and your teachers. They are your best guide.
Thank you, sir. Sir, we have one more question. We have one more question, sir. That is there is a lot of conferences happening on different topics, right? That is there, and many of our youngsters, they are very confused that which ones to join. Are there any benefits of joining the conference or something? Because since the COVID has stuck us, there's a lot of things happening on the virtual world, and on the virtual platforms, there's a lot of conferences happening, right? That is there. So the query of most of the students is, what are the benefits of attending and joining those conferences, and how to select which one to attend?
I 100% agree with you. If it was not COVID, there were lots of physical CMEs, conferences and workshops. And if there is COVID, then there was lots of online activities going on. And initially we all liked it also. There are certain advantages of online media, that you don't have to travel. You don't have to take, book your tickets, book your hotel reservations. So that is a good thing about it. And you can join it as per your comfort. But my suggestion is, choose your area of interest. Most of the time, what we do, we log in, but we don't listen to the whole talk. My suggestion is, if there are 3 talks, choose your topic which you want to listen and listen that particular topic. If there is some debate going on, some pro cons going on, listen to those, right? Case discussions, they are more useful, right? And then there are certain questions which are coming in your mind. You can put it to those teachers during those virtual platforms. And you cannot attend all meetings every day. So you have to be selective as per your area of interest, as per the knowledge you want to gain, which you think that you're a bit lacking, and also depending upon the teachers also who teach. So I think everybody knows that, okay, I can get this much information from this teacher on this particular topic in this particular class. So don't just log in. Stay there for 1 hour, 45 minutes, but at that time, leave your phone aside. Don't see the WhatsApp and focus on the lecture only. I think I am just answering your questions. If somebody has got different views or thoughts, they can also in between reply. It should not be a one-way answer questioning that I am expressing my thoughts. You can also express your thoughts, that they are most welcome.
Dr. Charan wants to ask a query. Dr. Charan, if you can please unmute yourself and put forward.
Good evening, faculty members. Good morning. Am I audible?
Yeah, very much, Dr. Charan.
Sir, how can ISA help to mentor youngsters to crack, if anyone wishes to crack any foreign examinations like EDAC, FRCA, for example? Can ISA help us with something, any young anesthesiologists who want to pursue in foreign examinations?
And I will be honest with you, as of now, we have online webinars only or classes only. Okay, how to get placements in international universities and international placements. As of now, cracking USMLE, EDAC, and PLAB, we have not started this thing. But yes, counseling is definitely given through the virtual media, how to prepare for this thing, how to crack. But that's a subject taken up in webinars. How to appear in foreign medical examinations and how to crack those examinations. I think we will have to make it a regular feature. Yes, this thing is lacking, and we have noted it, and we will start planning it.
Yes, sir. Thank you so much, sir.
Thank you so much, Dr. Charan, for joining us. Right, sir, we have similarly, there are a lot of academic related questions because we have youngsters, the young minds bubbling with they really want to do many of the things or something. So there's one question, it says that is ISA helping or supporting those young anesthesiologists who have some innovative minds to innovate something and for the benefit of their patients?
Definitely, we have got our ISA Innovation ISA Innovation Club for this particular thing, and it is being looked after by a team of Dr. S. Balabhaskar, Dr. Dulked from Karad, and then Dr. Vishal, Dr. Vishal from Gurgaon, Apex Patwa, and from Gujarat. So, if you have got some innovation, you can just take the advice of these people. They are very into it, and you can even take advice from them how to get it patented. So I think Dr. Dulked was here only. If he's there, we can invite him for his comments. Dr. Dulked, are you there? So by the time he joins, yes, there is a ISA Innovation Club for this, and they can guide you how to commercialize it also. First get patent, and then how to commercialize your innovation, and then how to publish it also. So definitely there is a full guidance on this, and you can go to our website in the ISA innovation session. So I think Dr. Dulked, are you there? So by the time he joins, we can move on to the next question.
Certainly, sir. I feel like that there's a lot of the activities ISA is doing, and our youngsters should actually visit our ISA website, right, which is there, and they should have versatility of knowledge on the ISA run programs for young anesthesiologists. They're available on the website. Sir, we have a query from Dr. Navnesh. Dr. Navnesh is working at AIMS Bhatinda. Dr. Navnesh wants to ask that what is ISA doing to increase the awareness about the role of anesthesiologist and public awareness kind of a thing? Is there any big things being done at that?
I'll answer that question, but Dr. Dhulkhed is here. Sir, are we audible to you? So there was a question by one of our postgraduates that how ISA can promote innovations being done by young minds. So for that, I said that we have got our ISA innovation cell, which looks after these things and helps you in guiding, patenting, and publishing, and even commercializing it also. So you want to add something, sir?
Yeah. The thing is, if anybody has any innovative idea, he should first thinking of patenting it. He should first apply for patent, then present here in the conference. Otherwise, later on, if he presents and make it publicized, then he cannot patent it. So that is what one of my things. And we will advise them how to get the patent lawyer and all that. There are particular lawyers, advocates, who are experts in getting patented and all that. They have to apply to the patent office, which we can definitely advise. And we have got one from the department, one or two patented innovations. And what happens is our institute, Krishna Institute of Medical Sciences, deemed University Karat, has got a dedicated patent cell. So when we present it, so they will patent it for us. They will spend all the money and all that. But if we want to do privately patent it, we have to spend money and you have to appoint a lawyer, an advisor for that particular thing. But first is keep it confidential before publicizing it. First, you have to apply for patent. Then after getting the patent application number, then you can present it or do it whatever it is. That is the thing. That's and so we are promoting so that this is a new and India is emerging now in startups and all that. So we have to encourage our anesthesiologists. See, in abroad and all, a lot of people are doing. See, even this LME and all that. So much struggle and it is so much widespread now. We want Indians to do like similar things, at least start at least, so that we will be emerging as a leaders. India is a huge country and a lot of talent is there, and we should utilize this talent for these things.
And you will be happy to note that after this session, immediately after this session, the ISA Innovation Award session is there, and you can listen to the innovations done by our anesthesiologists across the country. Immediately after this Yuva session is the ISA Innovation Award session also in the same hall. So any other questions or queries or comments you want to ask? I can see Archana has joined, or some other questions. If there are some, you can please, we are ready to answer them.
Thank you, Dr. Salatra. Nice to see you.
Thank you, sir. Thank you, sir, for joining us today and encouraging our young anesthesiologists, right? That is because ISA is doing a lot for them, including the innovation cell. So we were just discussing, and Naveen sir was also saying that, yes, we should get our website, as mentioned, also isaweb.in, where a lot of national programs are being mentioned. Sir, the next question, but again pertaining to academics, is there is ISA doing anything, something like a digital library or a virtual a library where all the journals and all collective things can be accessed? Because in a bigger cities they may have access to all those things, but at far off places, our students are lacking on that. Is ISA working?
See, there are, I think, definitely all the academic material, all the webinars, their videos, and all our practice guidelines of ISA, they are available on ISA website. So see, we have recently published practice guidelines for fasting and feeding in perioperative period for pediatric, obstetric, and obese patients. So they are available, published in IJ also, which is in a PubMed Index journal, and they are available on ISA website also. So whatever academic thing which we are doing, they are available on the ISA website, number one, either the videos or the text form. Secondly, IJ is available free of cost online, www.ijweb.org. You can go and download those articles. Yes, there are old journals also which are there, which were not online at that time. We are planning to compile them and keep as archives on digital platform. We are also coming up with few new things as ISA virtual museum, right? So it will be a virtual museum for old, from where we started, the old equipments to the current one, because at times we talk about history of anesthesia outside the world, but we should be focusing about the history of anesthesia outside the world also, but history of anesthesia of India also, and also history of ISA also. So that will be available on the digital platform. We are also working on ISA physical status grading. We always have been talking about ASA physical status grading. So that is also an ambitious project which has been started. And so we are working on all these things.
Thank you so much, sir. Before I put forward a last query, anybody from and the participants who have joined us today virtually, anyone has any query, you can unmute yourself and ask, sir. Okay, sir. So with your permission, this thing has come to us from many young anesthesiologists across the nation. If I am not wrong, this query I have got from almost 10 to 11 our young budding anesthesiologists. That last year on a very virtual platform, ISA National Headquarters have conducted Yuva ISACOON, right, which has given a wonderful platform for our young budding anesthesiologists, right, to participate, and even as a faculty, they're participating in papers or something. So is there any plan of ISA conducting the same event this year as well? And if yes, when and how?
Yes, I'm very happy to share with you that the first YuvaCon, which was held in 2020, 5th September, was the first ever online conference of any medical specialty in India. 2 days, and we opened the floodgates for the online conferences by the different ISA branches. And yes, Dr. Amit, you were one of the close coordinators in that YuvaCon. And I'm very happy to share with you that we are now into our Platinum Jubilee year. ISA was formed in 1947, and we're entering into 2022. So as a part of our ISA Platinum Jubilee celebrations, we will be celebrating throughout the year of all ISA programs at all levels, city, state, metro, and national level, of all ISA programs, academics, clinics, extra curricular, social, everything. We will be conducting them. And as a part of that, I take this opportunity to announce in this fora, the Yuva session, that now earlier it was a national event. Now it is an international event, which we are going for Global YuvaCon on 3rd weekend of January. It will be on a virtual mode for those who are not able to travel physically. Those who are able to travel physically, we'll have a small gathering at Rohtak, Haryana, my native place. and you are all welcome and motivated to participate and present your work in that conference. Also, the award winners in different categories of this conference, ISACOON 2021, will be given a faculty position in Global JuvaCon. So all those who will be winning prizes here will automatically get a complimentary registration and a faculty position in the Global JuvaCon in appreciation of your work. So I think now we are heading towards the close. Time is running out for us, and next session has to be started. So my humble request to all of you is that Yuva ISA is the future of ISA. You are the doctors who are going to treat the future generations and even us also, right? So you have to be trained and taught, and you have to be taken care much better than we ourselves. So ISA is your own body. I can say proudly it is for you, of you, and by you, and you're the backbone. If there is any suggestions from your side, most welcome. You want to say, sir, don't, ISA should not do this thing, be open and blunt. Or ISA should do more of such things, most welcome. And constructive criticism is also most welcome. And please give your inputs and participate in ISA programs. For Yuva.
Put one more, sir.
Yes, sir, please.
Some more ideas.
Go ahead, sir. Go ahead.
This innovation that I wanted to little more add on that. See, we have got leading science institutes in the Tata Institute of Fundamental Research, Indian Institute of Science, IITs. So many IITs are done. AIMS are there. Then we have got wonderful software. We are the leading software people in the world. So we can use all these areas, all these things for innovations. So young people especially should come out with innovative ideas so that we can incorporate artificial intelligence, software programs, and then make newer implements. So many ideas are there, and you have to take active part in that. So that is my appeal to all the anesthesiologists. We are lagging behind in anesthesia research, especially in this area. So we can take, India has a huge potential and huge talent. So why can't we make use of it? So that is why we have created Dr. Bal Bhaskar, and a couple of years ago, we had a discussion what new things we have to come out in ISA national programs. So I suggested to him this innovative thing, because this is where we are lagging behind. See, some people come out with so the target controlled infusion and all that, but some they're all assorted and all that. But we have to create our own things in video laryngoscopy. So much wide scope is there, and India has got huge talent. So we have to make use of it and come out with new ideas and become, so to say, leaders in this field. We are lagging behind that in technology and these things areas. So that is why we have come out with this innovative platform to give awareness and impetus to the people. So this is some of my ideas I wanted to just.
Thank you, sir. Thank you for your inputs. And I finally conclude this session by saying to all my dear postgraduates, senior residents, and Yuva ISCians that there are 3 mantras in life which I follow, and I suggest those to you also. Honesty, sincerity, and hard work. Follow these 3 mantras and keep on serving the patients and the society with good intent. The blessings of patients and your parents and teachers will take you to newer heights in life. Thank you all for joining this session. And this was the first Yuva session started in ISACOON 2021. And we shall meet you soon at Global JuvaCon on 3rd weekend of January. Thank you very much from ISA national side. We'll see you soon. Thank you very much.
On behalf of everybody present here, thank you so much, Naveen sir, for sparing your time for the session. An innovative idea to hold this session. And when the students have heard directly from ISA National Headquarters and our honorary secretary, specifically the one person who is able to even the young budding anesthesiologist of our country. Thank you so much, sir, for being with us today.
Thank you, sir. So now we are going to start our next session, the ISA Innovation Award session. I would like to invite judges Dr. Balabhaskar, Dr. Vital Tulke, Dr. Apex Patwa.
Actually, there are. Hello, is there anybody from the tech team there who is going to present the presentation?
Yes, sir, shortly.
So there are four abstracts for the innovation session. They have to present one by one.
Okay, sir. Okay, sir.
Okay, so you have got 4 presentations. You will do. Okay. So you please project the first presentation.
Okay, sir. Okay.
Everyone. First of all, I would like to thank the organizers for giving me this opportunity to showcase my innovation, which is an AD trainer for masses in their own language. And I have named it Punarispandan, which means restarting of heartbeat or pulse. Sudden cardiac arrest is the leading cause of death worldwide, and most of them are out of hospital cardiac arrest. And quality cardiopulmonary resuscitation and defibrillation is the key for survival after sudden cardiac arrest. However, it is not possible for emergency persons or medical persons to reach all the victims within the time. And to fill this gap, CPR training to general public is the solution. And if such trained bystanders act quickly and provide CPR, the chances of victim survival doubles. Many cardiac arrests are due to lethal arrhythmias. So it is the shock, not the CPR, that will reverse the lethal arrhythmias. And to deliver shock, automated external defibrillators are used, and popularly these are known as AEDs. These are small portable devices that can assess a person's heart rhythm and deliver life-saving electric shock if necessary. For training purposes, AED trainers are used, and these AED trainers looks like AED and has functions similar to AEDs except ability to deliver shock, which are available in our country, gives instruction in English, and English language is acting as a barrier for training during layperson. I have designed this AED trainer which gives instruction in Hindi and English, and the language can be customized in other regional languages also to suit the training to local people in their mother tongue. It has got 2 modes, one semi-automatic mode and other fully automatic. It has adult and pediatric pads. It has 10 scenarios which can be changed to make training more useful. It has got remote which can be used to change scenario, mode or language. And it is operated by 2 AA batteries which are easily available. A prototype of the device has been made and tested, and it has been demonstrated in front of Indian Resuscitation Council office bearers. It has got CE certification, and we are searching for industry partners for mass production and marketing so that this device can reach to the end users for the benefit of the society. Thank you so much for your patience hearing.
Yes, Doctor, are you online?
Hello.
Yes, Ashish.
Yes. Hello, everyone.
Sir Balabhaskar, sir, good afternoon.
Yeah, good afternoon. Please carry on.
Oh, allow me to ask the question, sir.
Please go ahead.
Yes, Ashish. So it's definitely a good idea to have a different language incorporated in the such type of trainer. So we can easily use this type of device in a local area. But the limitation for us, or if we think as a whole, so there has to be uniformity in each and every type of devices. Fine. So otherwise, what happens? So someone is not uniform. So it will be difficult for many people to use in a different areas. So that is most important thing. So you incorporate the same, consider the English as a base, and you are converted into the different languages. But when you are training the people in a different languages, and suppose they are traveling at other area where there is only English is available. So in spite of training, they are not able to do the job. That's the biggest limitation for us. So there has to be uniformity in all type of devices, even in the teaching. That's what I am thinking.
So that's why I have kept bilingual. So it's basically for lay persons, so who are not able to understand English easily. So that's why I have incorporated it in English, as well as it can be incorporated other languages also. But as a base, English can be kept. However, multiple languages can be kept in it. More than 2 languages can also be opted, but that will again increase the cost.
Fine. So one last suggestion. So is it possible to have a coding system for that? So coding can be applied across the world rather than language.
Yeah, coding is there. Coding is there. I have just translated the instructions for the local public.
Anyway,
Okay, sir.
Good innovation. I appreciate your effort in bringing it in regional languages. And one thing is, if you had demonstrated practically, one video on that would have definitely more appreciated. That is number one. So if you have video, you could have done it, no, practically. And from whose collaboration you have done this?
I have done it with some of the freelancers. I have paid them and get it done. Initially, I have tried to do it with IIT Kanpur, but it was taking a pretty long time, and they were not taking much interest in it. So I have got it done by myself with the freelancers. I have paid to the freelancers, and they have
Freelancers means electronic engineers.
Yeah,
software engineer.
Yeah. There are many freelancers which do your job.
Have you applied for patent?
No, it's not patentable because it's a software, so it will come under the copyright.
At least copyright you could have taken.
Copyright can be applied for it.
Yeah.
No, it's really a good innovative idea. I agree to that. Doing such thing alone is a Herculean task. We have gone through such phases. So meeting with the individual persons, explaining the things and getting things done. It took a lot of effort and lot of time also. I must appreciate your effort, Ashish.
Yeah, thank you so much for your effort.
Okay, thank you, Ashish. I will not have much comments because our only thing is, as Dr. Dulkar sir was telling, there could have been a brief video, so that all of us would get interested, and we will be supporting you also, at least morally. Okay, thank you very much.
Actually, I couldn't incorporate video due to time limitation. I have got the machine in front, so if you say, I can show you.
No, because of lack of time, probably, Ashish, we are not able to.
Okay.
But I suggest that you share a brief video, because all of us are part of ISA National Innovation Team. So you can just share a brief video later on.
Yes, sir.
Yeah, sure.
Dr.
I have demonstrated it to Chakra Rao sir and Mohit sir also. So due to time limitation of 3 minutes, I couldn't incorporate the video.
Just send on video link later on. Video
Yeah,
link.
yeah, sure.
Yeah, share with you.
Okay, thank you very much. Thank you.
Suggested.
Okay. Thank you, sir.
All the best for the future. We'll go to the next speaker, please.
And greetings from Mahatma Gandhi Medical College and Research Institute in Pondicherry. I am Dr. Archana, Assistant Professor in the Department of Anesthesiology. Here at our university, we have introduced an innovative competency-based postgraduate medical curriculum describing the sub-competencies and milestones to be achieved by residents. We have also implemented a formative assessments with the use of entrustable professional activities, all within the regulatory norms. First, we identified program outcomes based on global, national, and local needs. Next, we identified the domains of competency. Though the National Medical Commission has given a syllabus with 3 domains, we have expanded the affective domain to 4 further domains of competency. Within each domain, subcompetencies were listed, and the proficiency to be obtained in each subcompetency was written down as a descriptive milestone rubrics. In this sample rubrics, we can see each level has multiple nodes, each level of which is expanded into 4 or 5 levels and with increasing level of difficulty to signify progression. As you can see here, one aspect about assessment of airway starting with the normal to the difficult to the special population and finally in the compromised airway. When all these rubrics are combined, they make up the syllabus. Then we listed the EPAs. So a total of 21 EPAs for anesthesia were listed and described using the milestone rubrics, all the while keeping them aligned to the program outcomes. In a sample EPA description shown here, we have explained what the activity is, the domains of competency required, the subcompetencies within the domains, and also the milestone levels that need to be attained for grading of entrustability. The EPAs form a part of the formative assessment, and these forms and the direct observation are used to determine the milestone levels that are attained. Using this particular EPA assessment form, the levels attained can be written down. The upper half is used by the residents and the lower half is used by the faculty. Any discrepancy between these two is discussed with the feedback one-on-one, making the process transparent. Based on these milestone levels, the EPA is then graded based on a modified Dreyfus model, wherein only if all the milestones described for that particular activity are attained, then a grade 3 level of entrustability is awarded. The grades are then entered into this master progress sheet. The progression through the entire PG period may be documented. Residents are familiarized with this process at the time of their orientation. The self-assessment followed by a faculty assessment is done on a quarterly basis in the first year, followed by every 6 months till the end of residency. This entire process drives the training as the EPA grades done in confidence are used for feedback, mentoring, and monitoring. The entire process of the formative assessment in postgraduate medical education and standardized training ensures a quality control for practice readiness as independent anesthesiologists. With this innovative model and curriculum delivery of assessment, we are confident that it has the scope to be implemented to any training institution or hospital. Thank you.
Dulkar sir, it will be your field now.
Yeah, thank you, sir.
Thank you, sir. Please, sir.
Nice of you. Very kind of you. Thing is, curriculum is very important, and you have come out with a good software. I definitely appreciate, because in NAC assessment, curriculum has maximum value. They ask a lot of questions in one-to-one meeting in curriculum. So we faced a lot of questions in that, and we have come out with a software. Okay, but one thing I would like to ask you is, are you doing with this software in your institute, curriculum planning?
Yes, good afternoon, sir. We are not using a software as such right now. We are using we have separate forms that we use to assess each of these subcompetencies. So for example, we have directly observed procedural skill forms, which are again detailed. So right now we are doing it in a physical way, in using physical feedback forms. But actually our future plan is to actually implement it into a software based model.
Yeah, that is a nice idea. So I am also interested. If you can share your software with us, Suppose curriculum advances is there, what we call revision of curriculum. So every 3 year, every year at least 10% you have to add every 3 years. 10% has to be revised.
Yes.
So what is the provision in that?
Sir, actually, our list of EPAs and sub-competencies, actually it is quite flexible. So there is quite a margin for us to add and subtract and also modify based on what is the need and what is the curriculum that is prescribed by the national. Of course, it has to be aligned with the NMC. So definitely we do have that provision where it all, basically we formed it together using the expert committee of our department, and then further it has gone on to the curriculum committee, and then so on and so forth.
But have you tried it practically? Have you tried it practically?
Yes, sir. We have applied it. Actually, the first set of residents that are passing out now, right now they're in the final year. So we have just, undergone these EPA forms.
No, how satisfied you yourself or with your software?
We are not used as software, sir. So, but with using this assessment process, actually it has been, even for the student, they have understood what is expected of them, what they need to learn.
Anyway, it's a good one. I will also try in my department, in our university, and put it to UGC or such NMB national. From where you are? Which place?
I'm from Mahatma Gandhi Medical College in Pondicherry, sir.
Pondicherry, yeah. So that, when UGC team visits and all, you can demonstrate them, and you can apply for copyright.
It is already copyrighted, sir. We have
copyright. Very nice. Very nice.
University, and we are actually presenting it to the NACPIR team in the upcoming visit.
Yeah. That's nice. Okay.
Thank you, sir.
Should I have the permission to ask the question, sir, or time is over?
No. Please.
Please ask, sir. Please.
Yeah, it's a really good innovation, and so at present you are working with the physical forms, and future you are going to convert into the digital part. But that's good. See, I've gone through the detail what you have sent, and gone through your presentation. It's looking promising. It will definitely make the changes in the training. That's what I'm thinking. But important thing at the same time, should we, you don't think, should we have such type of format for teachers also? Because there is it's a diversified country, and teaching is different across the different areas. If you look at the teaching in Gujarat, if you look at the teaching in Andhra, if you look at the teaching in Assam. So we need to, again, this need to be uniform, and we should have such type of system for teachers also.
Yes, sir. Yes, sir. Definitely, we will need a lot of faculty development programs, and
Yes.
To train.
So then it will become more objective rather than subjective.
Yes, sir. Precisely, sir. I agree, sir.
Okay, thank you. We can go to the next presenter. All well done, Dr. Chandra.
Thank you very much, sir.
Respected all, very good morning. I clearly remembered the day of Durgashami, October 13th, while I was on my 24 hours duty. Around 6 p.m., I got a call from my ENT colleague that there is a kid who has ingested foreign body accidentally and it should be removed in the operation theater. The 7-year-old male child presented with history of foreign body ingestion, that is spherical marble, that is kancha goli, while playing, and he landed in ER with complaints of difficulty in swallowing, even for saliva. On examination, he was conscious, oriented, not dyspneic, not no stridor. His respiratory system and cardiovascular system were normal on auscultation. His abdomen was soft. The child not able to lie down in supine position since the salivary secretions get pulled in the throat. His blood and urine investigations were normal. This is the neck and chest X-ray of the child, where we are able to see a foreign body with smooth rounded surface at the level of cricopharynx. The ENT team had a discussion with emergency theatre team regarding choosing the most feasible instrument available. Though not much organized, the discussion was fruitful everyone came up with their own idea. The ENT team suggested laparoscopic biopsy forceps, but the goalie was larger for it to hold. The theatre staff nurse and theatre anesthesia technician suggested Babcock's forceps and Alice forceps. These had their own disadvantages. Actually, we had two requisites. One, the forceps should align with the oropharyngeal curvature. Second, the inner structure of the tip should be depressed so that the marble does not slip. So, I came up with the idea of modifying the McGill's forceps with rubber vial caps on the inner side of the tips. The outer rims of the rubber vial caps were trimmed, and each vial cap was secured to the closed tips with 4 silk sutures through the hole in the middle. Like this, we have secured the rubber vial caps in the McGill's forceps. Then the child was intubated and then held in head down position so that gravity could help us. With the help of modified McGill's forceps and the foreign body hook, the goalie was maneuvered and removed from the cricopharynx. The procedure lasted about 30 minutes and the recovery and post-op was uneventful. That completes my presentation. Thank you for the opportunity. Thank you.
Yeah. So this McGill forceps has not been modified since long time. So you have tried to modify it. Anyway, you have been successful, but you have to refine this whole thing and see how far it will be useful. Really. But was it not possible to remove the foreign body without attaching these rubber caps?
Actually, it's very slippery, sir. Because of saliva, the goalie was very slippery. I couldn't take it by using the other things, sir.
It's a good idea. Anyway, the small idea, they appear very small, but they are very important because when we see the history, McGill himself, with the help of ordinary tubes available in the these hardware shops, he invented the endotracheal tube. So these are very really innovative things you are doing. Anyway, good this thing, but you try to modify it further and refine it and apply at least for design patents.
Okay,
so
sir.
that,
Sure.
medical college and all that, it will be helpful.
Sure, sir.
Yes, Dr. Santil. See, this type is definitely a good technique to be used when you require to remove the foreign body. Same way, it's been reported such type of use in a different literature also to remove the tooth. With the padded McGill forceps. There is the rubber pad, they have added it to the McGill forceps and they have removed the tube. And even such type of technique even is reported to pull out the tongue in case of difficult airway for a fiber optic intubation. Okay. So this type of technique is already reported in the literature.
Okay, sir.
So it's definitely a new thing for many people, but I think we should not label it as an innovation. It's definitely a different method, different process, different technique.
Okay.
And but otherwise, say as a case report, it's excellent case report. But when it comes to innovation, I don't think it's really an innovation.
Okay, sir.
You did job, no doubt about it.
Okay, sir. Okay, sir.
Okay. So
anyway,
very good.
Such things.
Thank you.
Will be really.
Yeah. No, he has got that innovative brain now. Innovative mind is there, sir. That innovative thinking is there. It's very good that Dr. Senthil has done that. Thank you. And only thing is, outside of the innovation, there is some ethics issue here. You should not be mentioning the patient's name and all and displaying. Dr. Senthil.
Sir.
Name of the child and all should not be shared.
Okay, sir. Next time I will.
Okay, no, that's it's important when we speak in a public domain, and otherwise you have to take permission also. Best
Okay,
thing
sir.
is to just hide the name. Okay, so
Okay.
otherwise a good presentation. All the best for the future also. We'll go to the next session, please. Next presentation. Thank you.
Good morning. I'm Dr. Ganesh, Assistant Professor PJ Chandigarh. The title is Effect of Syringe Size, Flow Rate, Manufacture and Priming Method on Lag Time of Syringe Infusion Pumps. We all know that syringe infusion pumps are necessary for the better control of drug and fluids. Lag time is the time taken by the SIP to reach the set flow rate. The main causes for this lag time is the gaps between mounted syringe and the syringe infusion pumps, malfunction or defect in the infusion pumps, or inertia and the compliance of the syringe and the associated infusion lines. The aim of this study is to determine the effect of priming methods, various syringe sizes, flow rates, and different SIP manufacturers on lag time using fluke infusion device analyzers. After getting institutional ethical committee clearance, this study was conducted in the biomedical instrument and devices of PJ Chandigarh using Fluke's infusion device analyzer. 5 different manufacturer SIPs were used. 2 SIPs from each manufacturer were used, and the average of the 2 was used for analysis. 10, 20, and 50 ml syringes were used, and the rates tested were 0.5 to 50 ml per hour. This flow diagram shows the procedure we employed. For example, 10 ml syringe is used and it is connected with the, it is filled with the carrier fluid, then 200 centimeter HPT is attached to the syringe, and one other end of the HPT is attached to the infusion device analyzer. In the manual priming method, the HPT and the infusion device analyzer priming chamber is primed manually. After the priming, we attach the syringe into the syringe infusion pumps. Whereas in machine priming method, after attaching the other end of the HPT to the infusion device analyzer, syringe is mounted on the SIP, and the HPT and the infusion device analyzer priming chambers are primed using the bolus option of the SIP. The other steps are the same, that is the SIP is run at 0.5 ml per hour, and for 60 minutes hydrograph is generated, and from which the lag 50 and lag 90 is calculated. The same procedure is repeated for other flow rates and all other syringes and using all the other SIP manufacturers infusion pumps. This is a hydrograph produced after running the syringe infusion pump 5 ml per minute and 5 ml per hour. For example, it took at minimum 5 minutes to reach the 5 ml per hour. This is the experiment setup. This is the infusion device analyzer we used. And coming to results, when comparing the priming method, bolus priming method, which is done using the bolus option in the syringe infusion pump, has significantly lower lag time when compared to the manual priming method. Comparing the syringes, 50 ml syringes performed better, that it has the lowest lag time when compared to 10 and 20 ml syringe. Comparing the different manufacturers, even though there is no statistically significant difference, some syringe manufacturers, some infusion pump manufacturers are better performing. Coming to the comparison of flow rates, 0.5 and 1 ml per hour infusion rates have a higher lag time than the other flow rates. Coming to conclusion, priming of SIP bolus priming used by the infusion pump bolus option reduces the lag time than the manual priming. The possible mechanism may be the reduction of the mechanical slack associated with the system. Similarly, 50 ml syringe has the lower lag time than 10 and 20 ml syringe. The possible mechanism may be the higher inertia of the 50 ml syringe is easily overcome when the SIP is used for the bolus maneuver, priming maneuver using the bolus option. Lag time varies with the different SIP manufacturer, hence pre-procurement we should check the lag time. Higher flow rates have lower lag time. To conclude, use 50 ml syringe primed by the bolus option of the best available SIP and run at higher flow rates by reducing the concentration whenever possible to reduce the lag time. These are all the references. Thank you.
Take the questions, Pitch.
Yeah. So do you have specific lab there to find out the lag time?
Yes, sir. Recently, for the last 2 years, we have started a biomedical instrumentation hub in the PJMER in collaboration with the IIT, nearby IITs and the Punjab University Engineer Department.
Okay. And what was the method used to find out that lag time?
Sir, actually, our aim is we use the infusion device analyzer, which is made by Fluke, which is standard as per mentioned in the literature. Our secondary aim is to generate or manufacture a separate infusion device analyzer for with low cost and whatever the limitation associated with this Fluke infusion device analyzer we are trying to rectify. So this is a pilot study like that we did, and our next aim is to generate our own infusion device analyzer.
Fine, infusion device analyzer.
Yes, sir.
Okay.
So have you
And,
tested with the standard equipment, gold standard? What is the
sir,
gold?
this is the gold standard. So this infusion device analyzer is the this is the instrument used for checking of these infusion pumps whenever they are manufacturing.
So
But
have you what is your agreement level with that?
Sorry, sir.
What is your agreement level with the gold standard? Your
So
new
actually,
instrument.
this is the gold standard at present. It is available. In olden days, we used to check the gravimetric methods, and
No,
there
that's
are.
okay.
Yes, sir.
What I'm asking is, how is it comparable to available in the market? Your device.
That we didn't manufacture, sir. It's under process. We have manufactured a simulator of SpO2, like saturation. For saturation also, whatever the saturation we are measuring using the
So you are
monitors.
not, what is your innovation in this?
The innovation is that we are manufacturing a new device with low cost.
Manufacturing, not at manufacture.
Not at manufactured, it's under process. We
So,
manufacture the same thing for checking of saturation, similar saturation.
It is your model, which are computer generated model.
Yes, sir. Yes, sir.
It is a
So
computer model.
It's a proof of concept.
Yeah, see,
Proof
yeah,
of concept level.
Yes, sir.
So,
Yes, sir.
so if you are planning to have a newer device, so you are planning to incorporate such type of analyzer to calibrate in the device in between.
Yes, sir. We have to calibrate this device also. We want to calibrate the syringe infusion pump using this device analyzer,
Yes,
and this device analyzer also should be calibrated.
So what in your newer device, what you are planning to come out with? So you are incorporating this analyzer into the device, so
Yes,
it
sir,
can repeatedly analyze the thing. So there will be a possibility of auto analyzer.
Sir, the auto analyzer, we don't have that idea till now. Our aim is we should analyze ourselves every 6 months, what are the pumps we are using.
So yes, see what happens whatever the pump we are using. We don't know whether it is calibrated, whether it is delivered, what are the lag time, or lag time are increasing or decreasing. We are not able to judge.
Yes,
but if you incorporate such analyzer into the syringe pump and it automatically rectifying, auto analyzing every monthly or every 6 months, there will be a better idea. It will be a better device.
Yes, yes, understood, sir. This idea till now we didn't have, but it is a best idea, sir.
So you are establishing a sort of quality control mechanism in your institute.
Actually, we are having this biomedical instrument up for the last 2 years, and recent under the Department of Anesthesia only. And in fact, we are spreading the news to the other pathology department where they are also getting interest to come and check. Yes, it is accredited. Yes, sir. Yes, it is accredited. It is accredited, sir. Sir, actually, I don't know much detail, but it's accredited. Every year we are conducting the meeting also with central government. Some team is coming. I exactly I don't remember the name.
Doctor, you said
good guys.
from the prototype.
Sir, and the main thing why we want to present this also, like practical use also, like we think like 10 ml, 20 ml syringe is having less lag time, 50 ml is having more lag time, some assumption. But those studies have been done using manual priming. Like whenever we fill the syringe, HPT, we will prime manually and we are attaching. But in this study is showing that 50 ml syringe is having the lower lag time. It means because once we attach the 50 ml syringe in the syringe infusion pump and we are using the syringe infusion pump itself to prime the circuit, then whatever the inertia associated with the system is taken care when we are priming only. So it will definitely reduce the lag time.
So for the priming, do you have any method to measure the volume of priming?
Sir, it will indicate. So in the IDA, in the infusion device, it is indicating what is the amount we used. It is approximately 1.6 centimeters for the HPT we are using, and the priming chamber has some 2 ml. So 1.6 ml and 2 ml.
Okay. Now, what's your position in the department?
Sir, I'm assistant professor, sir.
Okay, you are a permanent employee and you are part of this, no?
Yes, sir. I'm a part of this instrument.
The current testing. Okay.
Yes, sir. Yes, sir.
Right. Okay. Thank you.
Thank you.
All the best.
Thank you.
Thank you very much. We have one more presentation, or it's?
I think it's
the technical team. Is there one more presentation?
No, sir.
Hello.
No, sir. There is no more.
These 4 are there, no? Okay.
Yes, sir.
So I think all of us thank on behalf of Dr. Dulked sir, Dr. Apeksh, and on behalf of ISA National, we thank the organizing committee for the conduct of this program, and of course, best wishes to all the participants. They have presented good works. All the best for the. Please keep doing it. We can interact with us also for simple reasons. Definitely, there is some. Dr. Dulked and Dr. Apeksh have got important knowledge related to innovations, so you can get in touch with them. Thank you very much. Good day to all of you.
Thank you, sir.
Thank you, sir.
Okay. Only 4 are there. Last time more were there.
Hello. Hello.
Yes, ma'am.
Can we start now?
Yes, ma'am.
Where
So
are the other
now,
judges?
now we are going to start our next session, the ISA All by Myself Award session. I would like to invite judges Dr. S. Harshur, Dr. Jaishankar Jana, Dr. Rupal B. Shah.
Hello. Can we start now? Hello.
Good morning. My topic for today is pulmonary edema post-emergency cesarean section. Acute pulmonary edema affects 0.08% to 1.5% of women during pregnancy and in postpartum. It is uncommon but life-threatening. Here I present a case of acute pulmonary edema post-cesarean section in a 32-year-old Gravida 3 Para 1 patient with twin pregnancy of 9 months posted for emergency CS due to scar tenderness. My patient Farheen Naz, with previous history of cesarean at 1 year back and 2 months old report of hemoglobin 9.2 grams, was admitted for emergency cesarean section. Her pre-op vitals were BP 140 by 82 mmHg, heart rate 109 beats per minute, and saturation 99%. On general examination, pallor was present. Patient complained of dyspnea grade 1, but no added breath sounds appreciated on chest auscultation, nor were any murmurs present on cardiac auscultation. LSCS was done under subarachnoid block and live twin babies were delivered. Cesarean section was uneventful and intraoperative vitals stable. Patient was comfortable, conscious with postoperative vitals of BP 110 by 68 mm of Hg, heart rate 106 beats per minute, and saturation 100%. 1200 ml of Ringal lactate was infused intra-op, and a urine output of 300 ml and blood loss of 150 ml were recorded during the LSCS. Patient was shifted to ward, maintaining saturation 100% on room air. After 50 minutes, patient complained breathlessness. On examination, oral secretions were observed, saturation 89% on oxygen 15 liter, heart rate of 136 beats per minute, and blood pressure of 170 by 100 mmHg were recorded. Patient was immediately shifted to OT, monitors attached, and was intubated. Endotracheal and oral suction was done, saturation improved to 100%. Coarse crepitations were appreciated on chest auscultation. X-ray chest AP view showed bat wing appearance in perihilar region suggestive of pulmonary edema, and ECG showed sinus tachycardia of 124 beats per minute. ABG examination suggested of metabolic acidosis with pH 7.01, PCO2 35.3 mmHg, PO2 62.7 mmHg, bicarb 22.9, and clinical assessment showing signs and symptoms of pulmonary edema. Positive pressure ventilation was given, injection sodium bicarbonate 100 ml intravenous, and injection furosemide 40 mg IV start repeated after 15 minutes were administered. Patient was then shifted to ICU and 2D echo was done, suggestive of global hypokinesia and hypertrophic cardiomyopathy with ejection fraction 55%. A hemoglobin of 7.2 gram was noted. Patient was kept on ventilator for 48 hours on volume control mode with PEEP of 7 mmHg. Weaning done and patient was extubated on post-operative day 3. 2 units of blood transfusion was done over a period of 3 days. Packed red blood cells were given. Patient was further kept under observation for 4 days, then discharged. Differential diagnosis for post-operative dyspnea include pulmonary edema, pulmonary embolism, amniotic fluid embolism, pneumonia, and foreign body aspiration. Dyspnea with pulmonary edema can be due to various cardiogenic causes such as peripartum cardiomyopathy, eclampsia, valvular heart disease, and myocardial ischemia, whereas non-cardiogenic causes can be iatrogenic fluid overload, thyroid disease, tocolytic drugs, and ARDS. The causes of postpartum cardiomyopathy are unknown, but risk factors include age more than 30 years, multiparity, African descent, pregnancy with multiple fetus, history of preeclampsia, eclampsia, or maternal cocaine use. Postpartum dyspnea has a wide variety of etiology, and appropriate and timely resuscitation and evaluation of symptoms are very important. Echocardiography plays an important role in patients with diagnostic dilemma, conservative management with ventilation, and medical line of treatment with post-operative vigilant monitoring and intensive care by anesthetists can prevent mortality due to postpartum pulmonary edema and hence decrease the MMR. Following are the references. Thank you.
Hello everyone.
Very well managed case, Dr. Navya. But after.
Hello ma'am. Hello everyone.
Hello.
Here we have Dr. Vijayanand with us as a judge.
Hello.
Yes, hello. Good afternoon, ma'am.
Good afternoon. Very well managed case. But after diagnosing pulmonary edema, you have managed the case in ward only, or you have shifted the patient to ICU?
No, we shifted the patient to ICU initially for 2 days. It was a private clinic setup which was having only a minimalistic ICU, I would say, with only 2 ventilators and no ICU trained staff. So it was a private small nursing home setup in which this particular case happened. Yes, ma'am.
So who was looking after that patient? You have continuously managed this case alone?
Yes, ma'am. I was the only one who managed this case in ICU along with an ICU nurse.
Where do you work?
Ma'am, I live in Ranchi. I work here. It was a case done in periphery. I'm right now a senior resident in RIMS Ranchi. But after I completed my PG, for some time I was doing private practice in which I managed this case in the periphery.
Okay, very well done.
Okay.
Any questions? Other judges? No other judges, right? Hello.
Ma'am, Dr. Vijayanand sir is there. I would like to invite Dr. Vijayanand sir.
Hello, Dr. Navya. Have you taken permission from the patient to discuss his name, her name, and everything?
No, ma'am. I'm really
you have
sorry.
to take permission for that. Right? In a medical legal this era, you have to take this.
Yes, ma'am. Yes, ma'am. I apologize for it, ma'am.
No questions, then we can move on to the second case.
Play the video. Hello. Can I play the video?
Yes.
ज्योति बोलो मेरा मेडिसिन लाई ज्योति
Good morning. My topic was the effect of varying time intervals between fentanyl and propofol administration on propofol requirement for induction of anesthesia. Aim. So administration of fentanyl before induction of anesthesia with propofol should facilitate smooth induction with the reduction of induction dose of propofol and its side effects. So the study was designed to examine the effect of varying intervals between fentanyl and propofol administration on the dose of propofol required for induction of anesthesia. When administered prior to intravenous induction, fentanyl acts as a synergistic effect with the propofol and also reduces hemodynamic response to endotracheal insertion and laryngoscopy. So my objectives are three. We have divided into three groups. Fentanyl 3 mics per kg was administered immediately before induction with the propofol, and fentanyl 3 mics per kg was administered 3 minutes before induction with the propofol, and we are giving fentanyl 3 mics per kg was administered 5 minutes before induction with the propofol. So requirement of propofol induction dose and hemodynamic parameters have to record. Inclusion criteria were ASA physical status 1 and 2, age between 20 to 40 years of age undergoing elective surgery under general anesthesia. Exclusion criteria: allergic to propofol or fentanyl, obese patient, anticipated difficult airway, respiratory, cardiovascular, renal, and cardiovascular diseases including hypertension, receiving any drugs likely to affect requirement of propofol and hemodynamic parameters, and a history of alcohol or drug use or dehydration and emergency surgery. Methodology: study design is a comparative study setting Velaman Medical College Hospital MOT complex. Study duration 2 months. Patient and participants. Patient came for elective surgery under general anesthesia, and sample size was after obtaining approval from the Velaman Hospital Ethical Committee along with written and informed consent. 120 patients were selected. We have divided into 40 in each group. Sample size was calculated by using NCS software. The significance level was considered as P less than 0.05 was significant, and chi-squared statistical tests were used to examine the normal distribution of the studied variables. Total propofol dose and propofol dose for induction means milligram per kg. Then movement and vocalization during laryngoscopy and during laryngoscopy and intubation, and additional propofol dose requirement, and hypotension and fluid boluses were calculated and divided into 3 groups. So my results: total dose of propofol required for induction was highest in group 2 and group 1 and group 2 and group 3. So dose of propofol required per kg body weight was significantly higher in group 1 as compared to both group 2 and group 3. So p-value was significant, which was less than 0.0001. And incidence of hypotension during induction was significantly lower in group 3 and group 2 than in the group 1, which was we are giving the fentanyl. After giving the fentanyl, we are giving the propofol immediately. So my conclusion: administering fentanyl 5 minutes prior to propofol causes marked a reduction in the dose requirement of propofol, along with the significantly decreased incidence of hypotension during induction. Thank you.
Hello, Dr. Ramji. Yours is a tertiary care hospital. So you are not audible to me. Hello. You are not audible to me. Please unmute yourself. Hello, ma'am. I can't hear him. I cannot hear you. Hello. Can you hear me?
Yes, ma'am. Yes, ma'am.
Now I can hear you. Yours is a tertiary care hospital. Hello. I cannot hear you.
Sir, you are not audible.
Hello.
Hello, sir.
Hello. Arushi, I cannot hear him. No. And the other judge is available or not? तो मैं ही हूँ रूपल मिश्रा तो, पर मैं सुन नहीं पाती उनको। नहीं, वो फर्स्ट कैंडिडेट के साथ पूरा हो गया मेरा, अभी सेकंड कैंडिडेट को आई एम क्वेश्चनिंग बट आई एम नॉट एबल टू हियर हिम।
वो उनकी तरफ से टेक्निकल इशू हो रहा है कुछ.
So what should I do? Hello, can you hear me?
Yes ma'am, yes ma'am.
Yours is a tertiary care hospital.
No ma'am, I am from technical team ma'am. उनकी तरफ से शायद वॉइस में इशू हो रहा है, उनके नेटवर्क इशू है.
Okay. So what should we do? We should proceed further.
मैम उनको शायद बोलना पड़ेगा कि वो रिजॉइन करें मीटिंग. शायद तब वॉइस आ जाए.
And such I am getting late. So either you continue or do something. Hello.
We will continue.
The next candidate can go for the next one.
Hello everyone, myself Dr. Ashwini Manzari. I'll be presenting a prospective observation study to assess the outcome of preoperative elective airway management using an aerosol prevention box by an experienced anesthesiologist at a tertiary care center. During COVID-19 pandemic, attempts were made to prevent the aerosol generation and its spread in the operation theatre. One of such improvisation is the use of aerosol prevention box at the patient's head end during airway management in the operation theatre. However, the presence of aerosol prevention box can make the airway management difficult. Hence, we conducted a prospective observational study to find out the outcomes of attempts of intraoperative elective endotracheal intubation by an experienced anesthesiologist through an aerosol prevention box at a tertiary care center. Primary objectives were the rate of successful first attempt endotracheal intubation using aerosol prevention box. Secondary outcome of the study are the time required for the intubation, number of attempts of intubation, number of failures to intubate, and the ease of procedure for an experienced anesthesiologist. Methodology. So how did we do this? The airway management of 200 adult patients who consented for the participation in the study undergoing elective preoperative endotracheal intubation in the operating theatre using an aerosol prevention box was observed by an independent observer at a tertiary care center. The case record forms were filled and necessary data was collected. The data was analyzed in terms of frequencies and percentages using SPSS software. The result of the study was we could analyze the finding of 200 patients undergoing elective preoperative endotracheal intubation in the major operation theatre using an aerosol prevention box by an experienced anesthesiologist. The rate of first time successful intubation was 76.5%, 153 after 200. 42 patients required second attempt and 6 patients required 3 attempts by an experienced anesthesiologist. Mean time for intubation was 108.5 seconds, whereas the median time for intubation was 80 seconds. There were no major airway accidents during the study. The incidence of upper airway injury was 4.8%. The conclusion of this study was the use of an aerosol prevention box for elective intubation. The rate of first attempt successful intubation and prolong the time required for the intubation. Use of an aerosol prevention box makes the airway management difficult even for an experienced anesthesiologist.
So next.
Now there's probably a 2-minute session.
Hello.
You can ask me.
Have you? I want to show the intubating box how you made it. Do you have any picture of that box? And have you encountered COVID patients or normal patients? Hello.
What's the name of that person? First one.
Hello.
First candidate, I'll get you the list.
Please.
Hello, can you hear me, Ashwini? Am I audible to candidate?
Yes, ma'am, you are audible.
I am asking to Ashwini. Is she there?
I think she's not
Can we proceed to the next candidate? As I am not able to hear them and they are not able to listen me. So kindly proceed to the next candidate.
There are no more candidates.
There are only 3 candidates. Hello.
Yes, ma'am. Yes, ma'am.
It is done?
Yes, ma'am.
Okay, thank you.
Hello. Hello.
Yes, ma'am.
Hello. My video is there all by myself. Hello. Hello, Rupal madam.
Yes, madam. They are telling him there is no one now the things is finished. But I think yours is left.
Yes, madam. My video is there.
But they are
Who
telling
is
that
coordinator?
I don't know.
Coordinator.
I cannot talk to them. They cannot listen me. I don't know how to deal with this.
Hello.
Hello.
Yes, ma'am.
Hello.
Yes,
my
ma'am.
my video, no? My video. Please run my video.
Ma'am, your video is not received.
No. Can you share the screen of my PPT?
Ma'am, wait a second.
Hello. Please share my PPT from your side. Hello. Hello.
Hello, shall
All
I
by
hear?
myself, Dr. Hina. Hello, Rupal madam.
I am getting
They are
late
sharing the screen.
and they are not sharing so anything.
Hello. 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 Here
Good
is the
afternoon,
discharge
everyone.
summary of the patient.
I'm thankful to organizing committee of ISACOON-2021
Thank
for
you very
providing
much
an
for your
opportunity.
patience.
Myself, Dr. Hina Chanwal, working as a professor and head of Anesthesia Department, Chiefs Medical College, Ahmedabad, Gujarat. Today, I'm going to speak under the heading of All by Myself. My topic is the management of the cardiopulmonary life support by the single hand. My relative, 61-year-old male patient, a pediatrician, collapsed at the road traffic accident in the village. He was semi-conscious and the pulse was steady. We took him to the nearest district hospital, Surendranagar, that is in the Gujarat state. Due to the lack of the imaging and the other healthcare facilities, plus in view of deteriorating condition of the patient, we decided to shift him at the tertiary hospital, Ahmedabad. It was a Diwali vacation time, and I was at my home, Surendranagar. I witnessed the entire event. I decided to accompany the patients in the basic ambulance with the emergency equipment because the distance from Surendranagar to Ahmedabad is around 150 kilometers. So run is 2.5 to 3 hours. I stepped into the ambulance, but in Hazal, I couldn't check the equipment in the details. After primary treatment, fluids on with a secured vein flow. On the way, the patient suddenly worsened and became unresponsive. There was no pulse, there was no breathing. So immediately I started chest compression and I couldn't find the bed. Moreover, laryngoscope was there, but it was without batteries. So I continued chest compression with mouth-to-mouth breathing. While giving the CPR in the moving ambulance, I fell twice and broke my calcaneum, for which I had a cast for the 3 weeks with bed rest. Eventually, at the end of all the story, I was able to revive him. I was in continuous communication with the neurosurgeon at the Sterling Hospital, Ahmedabad. Their emergency team immediately took the patients, and the patient was diagnosed with the subdural hemorrhage. These are the CT reports of the brain. Here are some of the X-rays of the shoulder where the clavicle injury was there, and here some of the cervical dislocation also there. So it was the overall multi-trauma case. He was treated conservatively in the neuro ICU for about 20 days. Presently, patient is fit and doing his practice even at the age of the 72 as a medical superintendent. Such incidents inspire us and make our efforts worthy, and we feel satisfied in our life. Here is the discharge summary of the patients. Thank you very much for your patience. Hello. Yeah, good afternoon, sir.
So, how challenging was it? This whole situation.
Yes, it was a challenging case. Hello.
Go ahead. How challenging?
Hello, sir.
Can you explain how challenging it
Yes,
was?
sir. Alone I have managed this case in the ambulance, sir. And the patient is a pediatrician doctor, sir. And when he got the accident, nobody was with him. And surprisingly, I was there during the Diwali holidays at my mama's home. And then I have taken a challenge to accompany him in the ambulance. And I traveled around 150 kilometers in the ambulance with a very high speed. And in the Hazel, I have not able to check these things, the ambu bag and the laryngoscope and everything. The ambulance was started, and when the patient got worsened suddenly in the ambulance, and no pulse, no breathing, so I started the chest compressions and everything. I was alone, the ambulance driver and myself only. And then during this traveling period, I have given the chest compressions, and then I shifted him into the Ahmedabad, one of the Sterling Hospital, corporate hospital, and then the neuro team had taken over to that patient, and that with God grace, the patient is survived. I mean, the pediatrician doctor.
And presently he is doing his practice. He's a medical superintendent, sir.
How long it took to resuscitate in the process of shifting?
Yes, sir. It is around 40 minutes, 40 to 45 minutes, because in the midway he lost the consciousness and the breathing and all that.
Then you intubated?
No, sir. I have not intubated the case because there was, no laryngoscope, no batteries, nothing was there. So I have given the mouth-to-mouth breathing and the chest compression. That's it, sir.
There was no ambu bag?
There was no ambu bag, sir. Even not ambu bag into the ambulance also. So I have given the mouth-to-mouth breathing, and I have used face shield as the curtain of that ambulance, sir.
Yeah.
Window curtain I have used as a face shield, and then I have given the mouth-to-mouth breathing, and then I started the chest compression. So around 40-45 minutes I have given the chest compressions, and by the time I have reached to the Ahmedabad with the patients, and the ambulance was in the very high speed.
Okay, that's a great work.
Thank you, sir. Thanks a lot. And the patient is one of my relatives, sir. And presently he is working as a medical superintendent. He is pediatrician doctor, sir.
Okay. Good work.
Thank you, sir. Doctor, sir. Thank you, Vijayan, sir. Hello, Rupal ma'am. Hello, madam. Rupal ma'am. Hello. Am I audible, ma'am? Hello. Hello. Yes, ma'am. But I think so. The judge Rupal ma'am is not able to hear me.
Hello, next is Ashwini. Hello.
Sir, you are audible, sir.
Next is Ashwin. Can she present it? Hello, ask the next candidate to present it, please.
Sir, we are already presented.
Presented? Okay.
Yes.
Yes, sir. Pardon, sir? All four are over. Yes, sir. Yes. Yeah, thank you. Yeah. Yeah, thank you.
So now we are going to start our next session, paper presentation.
The case of comparison of sevoflurane and propofol for the laryngeal mask airway insertion in the pediatric patients. Laryngeal mask airway has wide application in the pediatric anesthesia practice. Supraglottic airway device LMA has become a standard fixation in the airway management and filling a niche between a face mask and the tracheal intubation in terms of both the anatomical position and the degree invasiveness. It is simple, well-tolerated, safe, reusable, cost-effective method for the airway management in the pediatric patient. There is increased use of the LMA in the pediatric patient because of the ease of insertion, minimal disturbances in the cardiorespiratory system, lesser risk of the airway injury during the perioperative period. After the hospital's institutional review board approval, the present observation study was conducted between the 60 children of the ASA grade 1 and 2, aged between the 4 and 12 years, of either sex undergoing the various elective surgery procedures. Inclusive criteria effective surgeries ASA grade 1 and 2 age group between the 4 and 12 years. Exclusion criteria known allergy or the hypersensitivity to the study drug, respiratory, cardiovascular, renal, hepatic disease, congenital disease, and the patient at the risk of the aspiration, full stomach, and the upper GI surgery. And the data was labeled and entered into the Excel spreadsheet. Analysis was between the version of the software program, and the descriptive statistics include the computation of the percentages. All quantitative data were analyzed using the unpaired t-test. And the results were expressed as mean as d, and the p-value of the less than 0.05 was considered as statistically significant, whereas the p-value of the less than 0.01 was taken as highly significant. And the 60% of the ASA grade 1 and 2 aged between the 4 to 12 years of either sex undergoing the various elective surgeries procedures were selected by the sealed envelope technique and divided into the two groups, S and B. And the group S suggestive of the sevoflurane 6 to 8% inhalation, and the 50% of the O2 and the 50% N2, and the group B of the injection propofol 2.5 mg per IV. And the discussion shows the endotracheal intubation has long been considered to be the gold standard for the patients requiring the general anesthesia, and the development of the supraglottic LV device LMA can be considered as a milestone in the anesthesiology and became the inseparable part of the airway management. The supraglottic airway device provides an alternative method for the pediatric airway management that is easy to learn and the high success rate, and the sevoflurane and the propofol are commonly used agent for the induction of the general anesthesia in the children, with the LMA to reduce the complication of the endotracheal intubation. To conclude with, both the sevoflurane and the propofol are suitable agent for the LMA insertion in pediatric patients, although the induction time is shorter in the propofol and the LMA insertion time is shorter in the sevoflurane, and the quality conduction of the LMA insertion with the sevoflurane were comparable with the propofol. Further, sevoflurane has better hemodynamic stability and the less side effect like the pain on the injection apnea compared to the propofol. So the sevoflurane appears to be the equally good alternative to the propofol for the LMA insertion in the pediatric patients. Thank you.
Next participant.
Hello everyone, I am Dr. Jyotsna Baria presenting the comparative study of hydroxyethyl starch and dextran 40 on a blood sugar level during surgery under spinal anesthesia. Hyperglycemia is an undesirable common occurrence in perioperative period. Stress response due to surgery, anxiety or even venipuncture leads to epinephrine release which potentiate the hyperglycemia, hypertension, tachycardia and increased catabolism. Hyperglycemia is known to potentiate ischemic damage to brain, spinal cord, kidney, myocardium. It is also known to impair wound healing by interfering with the white blood cell function. Spinal anesthesia, which is widely used regional anesthesia, may cause hypotension due to pharmacological sympathectomy. Intravenous fluid as a preloading or co-loading during spinal anesthesia can be effective in the prevention of hypotension. Colloid and crystalloid both are used prophylactically as a preloading IV fluid to prevent hypotension. Crystalloid like ringal lactate, which is isotonic and has a short intravascular half-life and leaks into interstitial space, so large volume is required for the prevention of hypotension. Colloid, which has a high oncotic pressure, mainly confined to intravascular space, so less volume is required. Dextran, which is a polysaccharide and metabolized to carbon dioxide and water by the enzyme dextranase. It elevates blood glucose level due to degradation of the glucose polymer. Hydroxyethyl starch, made up of the large ethylated starch or the glucose polymers, which is metabolized by serum amylase to smaller molecules of starch polymers and the free glucose residues. The main objective of the study is to evaluate the effect of the preloading fluid dextran 40 and hydroxyethyl starch on a blood sugar level during surgery under spinal anesthesia. and to compare the effect of the both as a preloading fluid for their potential to raise the blood sugar level. In this study, 60 non-diabetic patients of ASA grade 1 or 2 were selected, and a patient or exclusive criteria is the patient who are in regular use of steroid, low hematocrit, and diabetic patient, and those not willing to participate in the all the procedure which require the intra blood transfusion. Pre-anesthetic checkup were done and written informed consent were taken. All the patients preloaded with the one of the group over the period of the 30-minute prior to spinal anesthesia, and all the patients randomly divided into three groups. Group C ringal-lected, Group D dextran 40, Group H hydroxyethoxystrate. And the capillary blood glucose level were measured baseline and then at a consecutive reading. And the demographic data is summarized as a mean and standard deviation. Intragroup variables were analyzed with the analysis of variant test, and the probability value of less than 0.05 was considered as a statistically significant. In this study, age, gender, weight, and the duration of surgical procedure were comparable in all the group, which is statistically non-significant. In these two graphs, effect on mean arterial pressure and effect on pulse rate were taken in the regular time interval in the three group and comparable from baseline to the different time interval, which is not significant. In this table, the comparison of the average rising blood glucose level were seen. In group C, the maximum rise in blood glucose level at 45 minutes. In group H, maximum rise at 60 minutes. Then after remaining high in the both the group but within a physiological limit. Whereas in group D, maximum rise in capillary blood glucose level at 45 minutes and which is remain consistently high. In this graph, the comparison between group C and group D, there is a significant difference in capillary blood glucose in group D compared to group C. In this graph, the comparison between group C and group H, there was a significant difference in capillary blood glucose level in group H compared to C, but both the group it was remain within the physiological limit. In this graph, the comparison between group D and group H, there is a highly significant difference in capillary blood glucose level in group D as compared to group H. Thus, we concluded that under stressful condition, ringal-lectate and hydroxyethoxystrate significantly raised the blood glucose level, but it was within a physiological limit. Whereas dextran 14 raised the blood sugar to a level which is well above the physiological limit. So, hydroxyethoxystrate is a better as a preloading fluid. Thank you.
Can I play the next video? Hello.
Greetings everyone. I am Dr. Naveen Khurana and I'll be presenting a paper which is titled as Comparison of the Anesthetic Effect of Perineural and Intravenous Dexamethasone as an Adjuvant to Bupivacaine in Supraclavicular Brachial Plexus Block. Effective postoperative pain control is an important component in the care of surgical patient. Acute postoperative pain can be adequately controlled with peripheral nerve blocks using local anesthetics, which is further enhanced by use of additives which could be opioid or non-opioid. Dexamethasone is one such additive which is a highly potent glucocorticoid which can be given along with the local anesthetic either around the nerve perineurally or intravenously. Dexamethasone has both anti-inflammatory and analgesic effect, and it lacks the side effects like sedation and respiratory depression seen with opioids. So the primary objective is to determine the difference in mean time of onset of sensory and motor block in both the groups and to determine the difference in duration of analgesia in both groups. It is a hospital-based randomized interventional study conducted in patients between 25 to 60 years of age who were randomly allocated into two groups, Group A, perineural group, Group B, intravenous group. After obtaining an informed consent, the patient was laid in supine position. Under all aseptic precautions, ultrasound-guided supraclavicular brachial plexus block was performed on the site to be operated with 0.5% bupivacaine, and dexamethasone given either as perineural administration or intravenous. Onset of sensory block was assessed between time of injection of local anesthetic and disappearance of pain by pinprick at a Holman score of more than 2. The onset of motor block was determined as time from injection of local anesthetic till motor paralysis equivalent to modified bromide score 2. Intraoperatively, hemodynamics were monitored. Postoperatively, the duration of analgesia was noted as time between the end of local anesthetic and the first administration of the first rescue analgesic. The numerical pain scale was used. The following results were obtained. The comparison of time to onset of sensory block between both the groups was assessed as the time of onset of sensory block was faster in perineural group as compared to the intravenous group. Similarly, time to onset of motor block was significantly faster in the group receiving dexamethasone perineurally as compared to the intravenous group. The mean duration of analgesia was similar in both the groups, and the time to return of motor block was also similar in both groups. So basically, supraclavicular brachial plexus block is an excellent alternative as it has a lot of advantages like less blood loss, superior surgical conditions, and optimal postoperative analgesia. Ultrasound guided brachial plexus block has the advantage that it helps in accurate nerve localization, and it avoids a lot of complications of intravascular and intraneural injections. And the use of adjuvants along with local anesthetic further results in a prolonged duration of post-op analgesia. So basically, we conclude that perineural dexamethasone as an additive to bupivacaine results in a faster onset of sensory and motor block as compared to intravenous dexamethasone for upper limb surgeries under supraclavicular brachial plexus block, whereas the duration of analgesia remains the same in both routes of administrations. Thank you.
Good morning, I'm Sharif Tunisa here to present hemodynamic changes and block characteristic comparison among parturients receiving whole bupivacaine heavy, a comparative study. Our main aim of the study is to compare between the two groups receiving cold bupivacaine and heavy bupivacaine to identify the specific objectives which include onset of analgesia, sensory block, motor block onset, regulation of sensory and regression of the motor respectively. Lacuna is we couldn't measure the temperature directly and couldn't obtain the exact value. Also, we couldn't measure badicity and viscosity. We do not examine the post-op complications as such. Methods include prospective observational study conducted in a gynecological and obstetrics department at Bakula Samlani Medical College, Pakuda, after ethical clearance. Inclusion includes 18 years and older females of ASA grade 1 and 2 with singleton pregnancy above 37 weeks of gestation scheduled for elective seizure. Exclusion criteria includes unwilling patients, absolute and relative contraindications, parturients with anticipated difficult intubation, non-singleton pregnancy, BMI more than 35, and other comorbid conditions, and alcohol and drug abuse. Blinding includes double blinding to minimize the bias, randomized into two groups for minimization, group C being cold temperature, group R being room temperature. Sample size is being calculated as 30 in each group, totally amounting to 60 by following equations. This is the instrument used to measure the temperature in group C and group R. Result analysis, there was no significant difference in age among the two groups. Block characteristics showed a statistical significant difference after application of student fetus from onset of sensory block to motor block regression. The distribution of maximum level of sensory block was higher in group R compared to group C because of the higher cephaloid spread of the drug. Therefore, the FVP also fall was higher in group R compared to group C in first 15 minutes. There was no much significant difference in diastolic blood pressure and mean arterial blood pressure comparatively. Heart rate showed a significant difference in the first 10 minutes in group R compared to group C. Coming to discussion, Alex and et al. Have showed a higher increase in the use of regional anesthesia compared to general anesthesia in anticipated difficult intubation and also to avoid aspiration. In our study, as compared to Sinister and colleagues, we obtained that there was more upward distribution with higher temperature bupivacaine compared to lower temperature bupivacaine. Also, according to Bosworth and colleagues, there was a prolonged duration of block with higher temperature bupivacaine. But in our study, it was more prolonged duration of block was seen with cold temperature as compared to the room temperature. Similarly, Avia and colleagues, as our study, reported a higher cephalide spread with a higher temperature of bupivacaine. Hansi and colleagues have reported a slower and lower range of spread and quicker regression of sensory blocks at lower degree temperature, similar to our study. But in our study, we have seen a quicker regression in case of higher temperature, around the room temperature than lower temperature. Calliston and Collins reportedly showed a 2-segment regression time shorter in case of higher temperature bupivacaine, which is same in our study. The level of the sensory block obviously will predict the hypotension in a patient. The higher the level, the more is the hypotension. In us, similarly, group R, being the higher temperature side, received the more hypotension in the first 15 minutes compared to the lower temperature bupivacaine. Hartman has also been reported the risk factor for hypotension being the sensory block level. In conclusion, cold temperature is much better than room temperature bupivacaine in terms of block characteristic and also hemodynamic stability. These are my references. Thank you.
Sneha Bhute, Geriatry at Ashwini Rural Medical College, Solapur. Introduction. Post-operative nausea and vomiting is a common problem and distressing symptom in surgical patient population. General anesthesia with inhalation agent is associated with the average post-operative nausea vomiting incidence of 30 to 40% in surgical patients. These factors prevent the patient returning home at the end of the surgery and necessitating the readmission to the hospital. Nausea is defined as the unpleasant sensation associated with awareness of the urge to vomit, and vomiting is defined as the forceful expulsion of the gastric content from the mouth. Nausea and vomiting causes dehydration and electrolyte imbalance, and these factors reduce the quality of the life. The aim of the study was to compare the efficacy of ondansetron and granisetron on postoperative nausea vomiting in patient undergoing general anesthesia, and objective of the study was to determine the efficacy of both the drugs on postoperative nausea and methodology. It is a pilot study in ASA 1 and 2 patients coming to tertiary hospital undergoing surgery and scheduled to receive general anesthesia. Study group received injection granisetron 3 mg IV and control group received injection ondansetron 8 mg IV. Study location was Ashwini Rural Medical College, Solapur. Study population between age 20 to 60 years. Sampling method is random sampling with patient allocated even and odd groups randomly. Sample size of 50, that is 25 patients in each group. Parameters was post-operative nausea and vomiting. Inclusion criteria ASA 1 and 2, age between 20 to 60 years. Exclusion criteria ASA 3 and 4, pregnant and lactating women, age less than 20 and more than 60, and allergy to any of the drug. After approval from the institutional ethical committee, this pilot study was conducted in Department of Anesthesiology, ARMCS, Solapur. Data collection method, patient pre-anesthetic checkup done and basic investigation done, which were within normal limit. Preoperative baseline values were recorded, and informed written consent of surgery, anesthesia, and consent for study was taken. Patients were taken to operation theatre, and multi-parameter monitors were applied, and baseline vitals were recorded. After venous cannulation, all the patients were pre-hydrated with 7 ml per kg ringer lactate solution. Pre-medication was given 10 minutes before induction of anesthesia with injection glycopyrrolate 0.2 mg IV, and then a study drug was injected. Control group received injection ondansetron 8 mg IV, and study group received injection granisetron 3 mg IV. After 3 minutes, patients were given injection midazolam 0.04 mg per kg and fentanyl 1 microgram. After pre-oxygenation for 5 minutes, patients were induced with injection propofol 2 mg per kg IV, and injection succinylcholine 2 mg per kg was given. Then under direct laryngoscopic vision, trachea was intubated with endotracheal tube of appropriate size, and after checking the position of the tube, secured and air entry checked equal on both sides. Anesthesia was maintained with 60% nitrous oxide, 40% oxygen, and sevoflurane. Propofol infusion at the rate of 10 ml per hour, and top-up dose of injection vecuronium 0.04 mg per kg was given intraoperatively with controlled mechanical ventilation. At the end of the surgical procedure, attempt of respiration assist, and then patient were reversed with injection neostigmine 0.05 and glycopyrrolate 0.008 mg per kg. After thorough oropharyngeal suctioning, patient was extubated when fully awake. Intraoperatively vitals were stable, and patient then shifted to recovery for further observations. Postoperatively, patients were monitored by resident doctor for nausea and vomiting for 1, 4, 9, 12, 18, 24 hours by visual analog scale. Nausea was measured by 11-point numerical visual analog scale. 0 is no nausea, 10 is worse nausea. A score of more than 5 was considered severe, and score of 4 or less is minimal nausea. Total number of episodes of vomiting were counted. All the results were recorded and was analyzed statistically. Statistical analysis was done by man-made U-test, t-test, and chi-square test. P-value less than 0.05 will be considered as significant. The demographic data of the study population is presented in Table 1, showing that the two groups contain individuals with comparable demographics. Assessment of the post-operative nausea and vomiting presented in Table 2. During 1 to 4 hours, statistically significant difference was present in nausea was poor between both the groups, and between 0 to 1 hour and 4 to 24 hours, statistically insignificant difference was present. There was no statistically significant difference between two groups for incidence of postoperative nausea, vomiting, and need for rescue antiemetic. Both the drugs were well tolerated. Discussion: there was no statistically significant difference between two groups for incidence of postoperative nausea, vomiting. Intraoperative or postoperative hypertension, myocardial ischemia are the confounding variables in my study, but patients were normotensive in perioperative period and no adverse anesthesia events occurred. Conclusion: Granisetron 3 mg and ondansetron 8 mg are equally effective and safe in decreasing the postoperative nausea, vomiting in patients undergoing general anesthesia. Thank you.
I'm Dr. Ritam, and my paper discussion is responsiveness of state and response entropy and algorithmetry during intravenous fentanyl administration in male and female patients. Pain is often the most frequent complaint in clinical practice, and gender plays an important role in perception of the pain. Entropy is EEG-based monitor and consists of two components: state entropy and response entropy. State entropy reflects hypnosis component. Response entropy reflects algorithmetry is the quantification of the sensation of pain. Objective assessment of the pain sensitivity is performed by use of the study is to assess the gender difference in response to fentanyl or response to study design. This prospective application study was the Institutional Ethics Committee approval, and the study site is named. This was calculated using statistical software. Sample calculation was done based on the study conducted by Vasilidasyam. And to in the above study, the post-bolus difference in response entropy between male and female while awake was used a difference of 2% in the entropy value with an alpha error of 0.05 and power of 90%. We need to enroll 126 patients in total into two groups of 62, each one male and another female. Inclusion criteria is a grade 1 and 2 patients, 18 to 60 years of age, and exclusion criteria patient refusal is a grade 3 or 4. Disease or injury affecting the CNS, psychoactive medication, alcohol or drug abuse, allergy to the test medication, renal or hepatic disease, compromised cardiorespiratory function, pregnant patients, psychiatric disorder, patients undergoing intracranial surgery, and approval from the Institutional Ethics Committee. The study was carried out over a period of 6 months on the patients aged grade 1 and 2, aged 18 to 60 years, half of them being males and half of them being females. Standard ASA guidelines are followed, and FPX 50 algorithmic of Bagley instruments were used in a study to identify pain threshold and pain tolerance. The standard protocol recommended by the manufacturer was followed by calibrating the algometer. The algometer reading at which the subject complex pain is called pain. Coming to the statistical analysis, all the data were corrected, tablet and checked for correctness and consistency. Statistical analysis was carried out using SPSS 22 and R environment, and Microsoft Word and Excel have been used to generate graphs and tablets. Descriptive and inferential statistical analysis have been carried out in the present. This is assessed at 5% level of. Coming to the results, state entropy on comparison between on comparison with student teachers. The response entropy, in this case also there is no not to be found any statistically significant. Algorithmic in comparison between student ages between the groups, it is found to be statistically. The results of this prospective observational study showed that there is no statistically between 1 to 4 hours. 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 Results of prospective observational study showed there is no statistical difference in entropy values between male and females after fentanyl administration. In our study, we did not find any statistical significant difference in response entropy and state entropy values between male and female during fentanyl administration. The results of this prospective observational study showed that there was no statistical difference. Coming to the limitations, our study mainly focused on changes in entropy in awake state, and we could not find significant gender differences after fentanyl administration. But we did not evaluate the changes in the intraoperative period. Further studies are required in domain to establish scientific. Coming to the conclusion, we conclude that the fentanyl administration has not influenced the entropy values based on gender and female. Gender and females had a initial low pain threshold and a greater increase in pain threshold after fentanyl administration. Thank you.
This is Dr. Ashna Pare, and the study was conducted in SMS Medical College and attached group of hospitals. Introduction. One of the main goals of anesthesia during intracranial surgeries is to provide a relaxed or slack brain. This brain will allow better retraction of the brain and thereby will reduce brain retractor ischemia. Now, intracranial hypertension is one of the major treatable causes of deterioration and death from severe traumatic brain injury. Increased ICP is basically defined as more than 20 mm mercury of pressure for more than 20 minutes in the absence of any noxious stimulation. Now, osmotherapy is frequently used to reduce the brain tissue volume and ICP during neurosurgical operations. Serum osmolality, it is basically defined as the concentration of all solutes in a given weight of water and is expressed as units of either osmolality or osmolarity. Normal values range between 275 to 295 milliosmol per kg. Now, mannitol and hypertonic saline are most commonly used hyperosmolar solutions in the treatment of elevated ICP. Mannitol is mostly recommended as first-line osmotic for the treatment of intracranial hypertension due to various causes. Hypertonic saline can equally be used in reducing ICP by dehydration of brain tissue and creates an osmotic gradient, causing decrease in blood viscosity, which leads to cerebral vasoconstriction and increase in plasma tonicity, favoring rapid CSF absorption. Now, clinical trials have compared the effects of hypertonic saline and menthol on ICP, and it has been concluded that hypertonic saline is as effective as menthol in treatment of increased ICP. Methods. It was a hospital-based randomized double-blind interventional study conducted after obtaining valid written informed consent. Inclusion criteria: patients undergoing craniotomy surgeries who are willing to give written informed consent, AC grade 1 and 2, and age between 18 to 65, GCS score more than 13. Exclusion criteria: with patients with raised ICP, electrolyte imbalance, and with severe respiratory distress. Sample size of 40 cases were included. Group A patients received 5 ml per kg of 20% menthol over a period of 15 minutes, and Group B patients received 5 ml per kg of 3% hypertonic saline over a period of 15 minutes. Now, patient undergoing elective craniotomy surgery under general anesthesia were included with endotracheal intubation, screening, PAC written informed consent was checked. The patients which were included in the eligibility criteria were included. Randomization and allocation of 2 groups using seal annular method. Group A received mannitol, Group B received hypertonic saline. We mainly measured the serum osmolality at T0 minutes and T120 minutes, and various other hemodynamic variables, heart rate, systolic BP, diastolic BP, urine output were measured at various time intervals. Statistical analysis done and conclusion was drawn. Results. All the groups were comparable with respect to age, gender, weight, height, sex, ASA status, and duration of surgery. There was no statistically significant difference in the demographic variables between the 2 groups. Brain relaxation score was mainly comparable in both the 2 groups, and there was no significant difference in both the groups. Serum osmolality. Serum osmolality was mainly increased in Group B, which is the 3% hypertonic saline group, as compared to Group A. Discussion: osmotherapy is frequently used to reduce ICP in patients with intracranial hypertension due to various causes. Our study compared the effects of equal concentration of 20% menthol and 3% hypertonic saline on intraoperative brain relaxation in patients undergoing elective surgeries. Now, the hemodynamic variables were mainly comparable in both the groups. Serum electrolytes and urine output was also measured. Serum sodium was higher in hypertonic saline group as compared to mannitol at the end of 2 hours. Brain relaxation score was comparable in both the groups as assessed by the surgeons, and it was a subjective finding. However, serum osmolality was comparatively higher in hypertonic saline group as compared to menthol at the end of 120 minutes. Now, various studies were conducted in 2015 also by A. Raghav and other scientists, and they concluded that hypertonic saline and menthol can be effectively used for intraoperative brain relaxation. In 2011, Kamal conducted 5 randomized clinical trials for on 112 patients on the study included hypertonic saline versus menthol for treatment of elevated ICP, and the findings suggested that hypertonic saline is more effective for the treatment of elevated ICP and can be established as first-line medical therapy for intracranial hypertension. Conclusion: our study concluded that 3% hypertonic saline and 20% menthol equally effective for brain relaxation patients undergoing elective surgeries for supratentorial brain tumors, and hypertonic saline caused increase in serum osmolality as compared to menthol at the end of 120 minutes of surgery. Thank you.
Can I play the next video?
Hello everyone, I am Dr. Bhavya and Raju, third year postgraduate in the Department of Anesthesiology, JJM Medical College, Davangere. My paper for discussion today is efficacy of nalbuphine in attenuating the hemodynamic response to endotracheal intubation. Direct laryngoscopy and endotracheal intubation is a noxious stimuli during airway management. This stimulus leads to increased sympathetic stimulation, thereby increasing heart rate and blood pressure. This in turn increases the myocardial oxygen demand, and this can have deleterious effects on patients with comorbidities like hypertension, ischemic heart disease. Hence, it is very important to attenuate this stress response. So, the aim of the study is to determine the efficacy of nalbuphine in attenuating this hemodynamic response during endotracheal intubation. This is a descriptive study conducted on 40 patients aged 80 to 60 years undergoing various surgeries under general anesthesia at a tertiary care center. It was performed after approval from the Institutional Ethics Committee. ASA physical status 1 and 2 were included in the study, and patients aged less than 18 years and more than 60 years, ASA physical status 3 and 4, any emergency procedures were excluded from the study. regular pre-anesthetic evaluation was done the day before surgery, and on the day of surgery, patient was the injection. The study drug nalbuphine was given at 0.2 mg per kg IV, and intubation was timed 5 minutes after the intubation. Patient was induced with propofol relaxed with scoline, and endotracheal intubation was done. Any endotracheal intubation 15 to 20 seconds was considered, and anything exceeding 20 seconds was not included in the study. The following parameters were measured: heart rate, systolic blood pressure, and the diastolic blood pressure, and the recordings were taken before and after giving the study drug at intubation 1, 3, 5, 10, and 15 minutes after intubation. The data collected were statistically analyzed, and the following results were obtained. There was no age, there was no difference, significant difference in the age groups, the response to age groups, and also between the two genders. And ASA1 and ASA2 also, there was no significant difference in response was seen. The results, the heart rate was, there was an increase in heart rate, and the mean heart rate at intubation was around 95 beats per minute. The systolic blood pressure during intubation was around 132 millimeter of mercury, and the diastolic blood pressure at intubation was 85 millimeter of mercury. Usually, when no drug or no other maneuver is done to attenuate the hemodynamic response, we can expect an increase of heart rate from 20 to 45%, and increase in blood pressure from 30 to 40%. In our study, nalbuphine attenuated the hemodynamic response well by an increase of only 15% in the heart rate, and systolic blood pressure by 11%, and the increase in diastolic blood pressure by only 13.7%. Various methods are adopted to attenuate the hemodynamic response. Nalbuphine is an agonist and an antagonist opioid. It is a semi-synthetic opioid. It is an antagonist of the mu receptor and agonist of the kappa receptor. Many studies have been done on the nalbuphine, and nalbuphine has been at a dose of 0.2 mg per kg, provides excellent attenuation of hemodynamic response. Unlike other opioids, nalbuphine does not come under the Narcotics Act and is easily available. It provides good hemodynamic stability with minimal depression.
Hello everyone, I am presenting a paper of comparative evaluation of intermediate versus propofol on hemodynamic response following endotracheal intubation in adult patients. The increasing importance of the safe anesthesia practice has attenuated the need for anesthetic technique with smooth induction and intubation, stable intraoperative hemodynamic, and rapid recovery with minimal adverse effect. The fluctuation in heart rate and blood pressure, though brief and well tolerated by healthy individuals, may be deleterious in patients with cardiovascular compromise. Choice of induction agent hence should be able to maintain a safe range of hemodynamic parameters: heart rate, systolic blood pressure, and diastolic blood pressure. Recent study was carried out to compare and evaluate the efficacy of propofol and idomidate in preventing hemodynamic response after laryngoscopy and endotracheal intubation in reference to change in heart rate and change in blood pressure. Total 60 patients of the ASA grade 1 and 2 of either sex and age between the 18 to 16 years posted for elective surgery were included and randomly divided into two groups. Group P includes injection propofol 2 mg per kg IV, and the group E, N is equal to 30, where injection idomidate 0.3 mg per kg IV given. A detailed pre-anesthetic evaluation of all patients were done. The effect of the IV induction agents were observed in relation to hemodynamic changes like heart rate, systolic blood pressure, diastolic blood pressure after induction, after intubation at 1 minute, 3 minutes, 5 minutes, 10 minutes, 15 minutes, and the 20 minutes of the intubation. The observation of this study were compared with the observation of the other study and between the two groups. Exclusion criteria are those taking the antihypertensive medications, patient with the cardiac, renal, hepatic, and the cerebral diseases, obese, pregnant, and the nursing woman, patient with anticipated difficult intubation, patient with history of suggestive sensitivity to drug used in the study, and the patient not willing to consent. All the continuous variables were recorded as a mean plus minus SD. The data obtained from each group were analyzed statistically by unpaid t-test using GraphPid software. P-value less than 0.05 was considered significant. Result shows demographic data are not significant with each other. Table 2 shows the changes in the heart rate were increase in heart rate after intubation in both the group, but difference was statistically not significant. Table 3 shows changes in the systolic BP where statistically significant decrease in the systolic BP in group P as compared to group E after induction and intubation. Table 4 shows that after induction and intubation, there was a decrease in the systolic BP in group P as compared to group E, which was statistically significant. In our study, we compare hemodynamic responses where after induction, there was a decrease in heart rate in both the group, but there was no significant difference between the two groups. This fall in heart rate could be attributed to the anxiolytic action of fentanyl, which was used for pre-medication. Around 10 minutes and after intubation, blood pressure was becoming normal as compared to pre-induction in group P, whereas in group E, blood pressure remains stable after induction, which shows that intermediate do not have effect on baroreceptor-mediated pressure response. Thus, intermediate provided better hemodynamic stability during induction and intubation. Propofol and intermediate reduces rise in heart rate and arterial blood pressure during the laryngoscopy and intubation, while intermediate shows lesser hypertensive effect. Incidence of pain on injection and bradycardia was significantly higher in group P. Conclusion is single induction dose of propofol intermediate attenuates the hemodynamic response in laryngoscopy and intubation. However, propofol caused significant hypotension while intermediate provided more stable hemodynamic conditions. If there were be no contraindication, it could be preferred over the propofol for general anesthesia, particularly in hemodynamic unstable patients. Thank you.
Bye.